And colleagues who have logged into this webinar. The story of cancer care or cancer is something जो हम किसी प्रकार से भी उसका वर्ड सुन लें तो एक भयंकर सा chilling feeling हो जाता है. Anywhere, whether you watch it on television, whether you watch it, speak about it, it sort of gives you some shivers down your spine. Having said that, we have walked a very, very long mile as far as being able to understand the disease as well as take care of it. To understand the disease, doctors, the ecosystem, which now is extremely wide, as well as government, supported by their policies, their interventions, has really moved this needle. Having said that, COVID came in as a huge disruptor of care, which derailed many things. And one of them, unfortunately, was in the realm of cancer care. So given this disruption and the fact that now we are gradually moving out of it, hopefully, to a large extent we've already moved out of it, what are the interventions, what are the steps that are being taken? And how is it that people who provide care, as well as the regulators and the providers of medication, can all come together to make sure that whatever lost time has occurred due to this unfortunate incident does not leave a permanent mark in the life of people all across our country, irrespective of demographies or due to socio-economic conditions. So I'll stop myself there. Our distinguished guests are the Director, Health and Family Welfare at Chandigarh, Dr. Suman Singh, and Dr. Anil Kukreja, who is the Vice President, Medical Affairs and Regulatory at AstraZeneca Pharma India Limited. So my first request would and give us a brief background as to where we are in oncology care, what are the statistics, and what does the future look like given the background that I've already said. Over to you, Dr. Anil Kukreja.
Thank you, Dr. Shabnam, and good morning, Dr. Suman Singh as well. Good noon to you as well. At the outset, I really want to welcome all the guests, colleagues, ladies and gentlemen who have really joined today's National Cancer Conclave with the theme of closing the care gaps. And I really want to thank Voice of Healthcare for bringing all the stakeholders together and providing this opportunity to us. And this thanks is from the bottom of our heart, because we know as a part of the cancer community that each one of you is showing the solidarity in raising the awareness about the cancer. And today, particularly, we are here to not only discuss about the disparities in the cancer care, and also how do we close the gap for all the individuals which are affected by this disease. Now, as Dr. Shabnam rightly mentioned, we have to also look at what's the burden. So cancer affects millions of people worldwide. There are reports from 18 to 21 million, and it's definitely going to increase significantly. Most important is it's the leading cause of mortality globally, accounting for almost nearly 10 million deaths happening in 2022, and every year it's rising. In India also, the incidence is likely to increase, and it's increasing, and it's again ranges in million, 1.46 million to 1.57 million. And again, this will be only the data which is captured in the formal registries. And the penetration of registries is still not, I would say, optimal. Now, unfortunately, not all the individuals will have access to the same level of knowledge, care, and the treatment. And this results into the gap in the cancer care, which needs to be addressed. And we all should be committed to closing this gap and ensuring that all the individuals have access to the best possible care. Now, looking at the one of the crucial gap in terms of a lack of awareness and access, I think it's very important that this awareness needs to be built, and access to the early detection and screening will significantly improve early diagnosis and will improve the outcomes for the patients also. As we all know, in majority of the cancers, if you diagnose in early stage, there is a potential curative therapy which can be given. The intent of therapy is curative. And unfortunately, still, we have close to 50% or more than that are detected at an advanced stage. So the only option is that you can only prolong the life, improve the quality of life. Still, it is important. But I think shifting the needle to early diagnosis and providing potential curative therapy will be very, very important. At AstraZeneca, of course, we are taking a lot of efforts in terms of not only partnering with Indian Cancer Society to generate the awareness around cancer screening at community level, enhance the capability building of healthcare professionals. And on this occasion, of course, on the similar occasion in 2019, we launched Ganga Godavari Cancer Screening Program, and we are expanding this every year. We are increasing the footprint of Ganga Godavari Screening Program, starting, of course, from the Ganges belt from UP, Varanasi. Now we have expanded to Karnataka, Kerala, Tamil Nadu, and Maharashtra as well. The whole purpose is that we want to complement the government efforts for facilitating the early detection of oral, breast, and cervical cancers at early stages, because these are most common cancers. So this is, of course, one of the initiatives which I wanted to talk about it today as our effort. But most importantly, AstraZeneca also has a bold ambition of discovering, developing, and delivering life-changing medicines, which has a potential to prolong or double the 5-year survival, and also moving more into the potential curative treatments. A lot of global clinical trials we are doing across the world, and we are also attempting and striving to bring these global clinical trials to India so that we not only contribute in global drug development, but Indian investigators and the institutes have the experience of these life-changing medicines earlier on during as a part of the development. We have also partnered with, as a business partner, we are working very, very closely with, as a part of India-Sweden Healthcare Innovation Center. It's a tripartite framework where academia in the form of AIIMS Jodhpur and AIIMS Delhi, the quasi-government institute like Business Sweden, the Trade Commissioner of Sweden, and along with other partners and AstraZeneca as a knowledge partner, we all work together to ensure that we have all stakeholders to contribute for improving the cancer care. We have an example, we have a live COE in AIIMS Jodhpur, which provides the ancillary care, which is not provided currently in terms of counseling, the physiotherapy, the dietary therapy, and all those care, which is currently not being provided as a part of the centers. And we want to evaluate that by providing this care, can we improve the quality of life of cancer patients? So this is the project which we are working on. At the same time, as part of India-Sweden Healthcare Innovation Center, we nurture the startups and we leverage the technology like artificial intelligence to see how can we deploy these emerging technologies and innovations to significantly improve and transform the patient outcomes. I'm sure we all know that it's not the task of an individual. the entire ecosystem and all the stakeholders need to work together, and only together we can and we will close these gaps which exist in cancer care. So maybe let me pause here and stop here, and if there are opportunities, I can answer subsequent questions as well.
Thank you. Thank you very much, Dr. Kukreja, for putting that out there. And I think you brought up an extremely important point, that healthcare, if anything, COVID has taught us that healthcare has moved away from its traditional doctor, hospital, delivery system to embrace an ecosystem where everybody, including individuals, are responsible for healthcare. So it's just not the government, the hospital, the doctor, the nurses. There's a responsibility of citizens also to come into the system and make things happen. And partnerships, as you mentioned, the Swedish partnership. So there are various ways of exploring, and platforms are there where we can build upon that. So with this, man, Dr. Suman Singh, if I may come to you. Chandigarh is a beautiful city with fabulous institutions. And all across the country, where you look at the age-like institutes, everybody proudly wears a badge and says, oh, I'm from PGI Chandigarh, right? And I've had the opportunity of working at ISB also briefly at Mohali. So it's very heartening for people to know, yes, it's like saying I'm coming home to make a safety here. So Chandigarh is a kind of place which I think from healthcare facility perspective has moved a lot. In fact, at one point in time, I believe you were looking at cities for healthcare to be developed, and you're very mature in public-private partnerships also. So given this particular intervention of COVID, ma'am, and the fact that you have these stellar institutions, what in your mind are the policy tweaks that are required? So one is when you look at it from a state perspective, that the state needs to do this. And perhaps, is there an opportunity? And I do know authors of the National Cancer Grid are in PGI Chandigarh. Are there any things that can be done as far as treatment guidelines, to Dr. Kukreja's points, that now all kind of treatment is available? Is there any thought process, or could you just share with us what is it that we can do to mitigate this negativity of disruption of COVID? Over to you, ma'am.
Thank you so much. I would like to thank you in the first place that you have given me an opportunity to interact with such multiple and multi-pronged platforms which can come together and give us a very consolidated area for cancer treatment. Primarily, I'd like to first talk generally on cancer. When we detect a cancer patient, it is not only the patient which is affected, it is the family. It is the entire family which has to face not only the disease, a financial burden, a space, the treatment, then the rehabilitation of the patient. Now, so far, I think we are recognizing that cancer has overtaken what used to be an era of infectious diseases, and now we have come to non-communicable diseases. And in non-communicable diseases, cancer has overtaken the other diseases at a very fast pace, whatever the reasons. The problem is we need to address them at a very fast pace, or we will be totally at wilderness what to do with these patients. Now, this involves first the detection, early detection, as Sir Dr. Anil mentioned, because that is a core point of this program, because early detection gives us very good outcomes with the prognosis of the patient and the quality of life of the patient. For that, if you see the current scenario, what happens is a patient is diagnosed and he is taken to a tertiary care center. What we need to be doing is need to be proactive, do a population screening for early diagnosis of the patients and early start of treatment. Early start of treatment, one, can only be done if the patient is diagnosed at a much earlier rate, rather than coming to us at a late stage where the mortality rates, as Sir mentioned, are very, very high. For this, I would actually advocate mass population and community participation. We need to sensitize all our population as we have done with other programs. See, we have had very successful programs where we have contained polio, we have eradicated smallpox. We can also do this, but we need to move ahead at a very fast pace. I would like that one of the major gaps which can be covered are, see, only the government sector can alone not take care of this. The private sector needs to set up, the NGOs needs to come in, CSR. They also, the industry needs to step up and take care of a certain, segment where palliative care, rehabilitation would be taken care of them. This would work a long way in taking care of the patients. In, if you mention Chandigarh, yes, the city beautiful and the city of medical treatment. I think tertiary care alone will not work. We need to go down to the primary level where all our field workers are sensitized, all our primary centers, the dispensaries, the health and wellness centers are sensitized to this, and there the population coming to us is actively, proactively screened so that we can catch the disease at a very early age. Now, the outcomes definitely make a difference for this. Now, I would say this should be team health, not only the patient, not only the community, not only the health officials or the paramedicals or specialists or the state or different institutes by themselves. It should be team health which will have to work together and then march forward to contain this disease.
Thank you, ma'am. I think you brought out some very, very interesting points. And the last one, I think, is the most important, team health. And so when you look at team health and the concept of screening, from whatever that I've been able to understand, in May 20, the screening process, there was a screening process for non-communicable diseases, which included cancer. And there was a stop put to it because of the COVID crisis. So the manpower was shifted, rightfully so, that was required. Now, when you look at it from a different lens, so our experience of COVID and how that panned out and how civil society, as what you said, and NGOs, etc., came and pressed in, is it time that we look at putting policy guidelines that going forward in the screening program, what are the various, so whenever we look at public-private participation, we look at blocks. This is a problem just now, we need it for this. But from a long-term perspective, especially to catch them young, right? When it's just starting and therefore the containment and the outcomes are better. Is there any possibility that for screening itself, the CSR funding and the taxation pieces that are attracted, can we look at them so that people are enabled to be able to put money into this, Dr. Suman?
So I would like here to come up with especially since you quote COVID. So COVID was an extraordinary time and extraordinary circumstances where everything came to a standstill. But during that time, we realized that there are certain diseases which actually need to be followed up. Cardiac conditions, cancer patients. I think we need to put in policy protocols that, God forbid, if we ever have a situation like this, how do we keep in touch with the patients, deliver their medication, get them to the institute for treatment? We will have to think of this. We have some certain good researches and examples where in collaboration with the other departments, health department managed to deliver the medications, get the patients to the hospital, and continue their treatment during even those extraordinary times. But these were done at very small levels and at local levels. So we need to replicate this, and we need to be prepared for future, that if any such situation ever arises again, how do we go about it? Now, when you talk of awareness and screening, so I would like to mention here that recently we've had the Tata Memorial set up a center in Punjab, in New Chandigarh, which is very close to Chandigarh. And we are proceeding ahead with the center for screening of our uh, rural area, where those people never come up and are not even educated about such things. And it is going to be a long term screening, not for 1 year, not for 2 years, a study and screening for the next 15 to 20 years, so that we know what the outcomes of catching them young, giving them treatment. And I am very happy to share that what Tata Memorial has shared with us, that they would be providing free treatment, free diagnostics, free treatment to a poor patient who cannot afford it. This goes a huge way. But if I would request on all platforms that if people, individual, industry, they could come up and adopt some of these people for their care, rehabilitation, for their treatment part. I think it will go a long, long way.
I think that's a great point because in some way I'm associated with the TB program. So the adoption of patients to take care of the non-medical but extremely essential part, and I think that is what Dr. Kukreja, whom I will come to next, also mentioned in his opening remarks, that in Jodhpur they're looking at it from a holistic perspective. So Dr. Kukreja, if I might come to you now. The registry or the way in which we capture the number of patients, right, definitely needs a relook. To Ma'am Suman's points that when you look at the villages, the tier 2, it's difficult to actually ascertain what is the true number. But having said that, obviously it is a definite substantive number, because they say 8% of deaths in India are related to cancer in some form or fashion. So it is a substantive number of that we are looking at. From your perspective, given the vastness and depth of experience in emerging markets, developed markets that AstraZeneca has, one of the things that has come to fore is that when all over the world we are addressing the treatment of patients, which has kind of been stalled because of this disruption, everybody is looking at what guidelines to follow, which will give faster results and the outcomes would be better. So there's a value-based relook at it. Any thoughts about it? Because when you look at access, as ma'am also said, if it's a poor patient, wo dar jata hai. You know, it's a bhayanik catastrophe in the family because it means so much of expenditure. So any thoughts on that, Dr. Kukreja, that do we need to, for our population as well as the accessibility issue being a thing? Ayushman Bharat is there, but any thoughts on how we can make this better? Over to you.
Yeah, thanks, ma'am. I think it's a very relevant question. As I think Dr. Suman Singh ma'am mentioned, it's very important that we look at this from a holistic point of view. I think the biggest impact will be if all the stakeholders come together, unite voices, and also unite actions, particularly in early diagnosis. Now, if we, one is improving the awareness, and I think health and promotion well-being centers across the country, which are being set up, I think they need to be given a responsibility, upskilling of those workers who are doing that, so that we really promote the health and well-being of the population and take that as an opportunity so that as a population, we become more aware and cognizant about the common signs and symptoms which should not be casually taken, and patients should be guided for a further care pathway in terms of diagnosis, so that the patient goes into the at a right center where diagnosis can be confirmed and validated, and that will result into early diagnosis. Now I'll come to the second point. So this is one where NGOs, community, the health and promotion centers, they all can come together and work together in terms of, now you rightly mentioned, is there any process? Is there any protocol? So I think that's a need actually, that we need to look at how do we create that holistic protocol and policy at a ground level where there is an opportunity for various stakeholders to come together. And I'm sure, Dr. Shabnam, there are many survivors of cancer or many volunteers who has some family member who have suffered from cancer. They would want to come and join the movement. Only thing is we have to create that movement and create that opportunity and give that platform to all the people who are really willing to come forward. So that's one. Now, second is when the diagnosis is happening, the world has already moved into, and we all know, say for example, lung cancer is no more a lung cancer alone. We are talking about EGFR positive lung cancer. We are talking about ALK positive lung cancer. We are talking about the ROS positive lung cancer. We are talking about PDL1 positive lung cancer. So the treatment of these different biomarker identified cancer types, and this is not only lung cancer, it is across the tumor types. So what are the biomarkers which will provide a specific treatment? So the right patient, right treatment at a right time. I think that ecosystem needs to be built. And I think there are efforts from the government already. Diamond project is there, which has actually included some of the key biomarker. The need is to increase the budget outlay and increase the number of biomarker tests being incorporated in this program, and hub and spoke model to be created so that patient doesn't have to travel, the tissue doesn't have to travel. The hub and spoke model in such a way that the logistic solutions can be provided where tissue travels and the diagnosis reaches to the patient along with the tissue back. So that kind of environment and policies and protocols needs to be created so that biomarker defined cancer type is diagnosed early on, so that potentially curative treatment can be given, and therefore you are able to prolong the long-term survivor. And these survivors then come back into the system to take care of the other cancer patients also. So I'm just thinking, although it is a dream, it's a wish, but I think it's important that we all work together to create that holistic ecosystem of cancer care.
I think we've lost Dr. Kukreja, can you hear me?
Yes, I can hear you.
Right. No, I think you brought out excellent points. And, unfortunately, what happens is we all come back to the point of the budget, right? But while, yes, there is never enough money, and this is not only for health, for anything, there's never enough money, because research, innovation pushes the boundaries of everything. But I think somewhere along the line, we need to come to a place where you can't boil the ocean, but we can certainly pick up some areas. So clearly what I can hear both Dr. Suman Singh and yourself say, that in the realm of screening, picking them up quickly, there's a huge opportunity. There's a huge opportunity in upskilling and leveraging the primary health centers and the staff there to be able to bring the patients in. As far as newer medications are concerned, and I'll turn to Ma'am Suman Singh in this, that the newer medications, ma'am, having better outcomes, less of side effects, is undoubtedly out there. But then this cost angle comes, which becomes a huge deterrent. in that, what would what is it that the state of Punjab is doing, especially in tier 2 and tier 3, to enable people to cross this hump? It's not necessary that everybody needs to get the high ended. After all, now you also have CAR T cell therapy for cancers, but it's not, you can't afford it, right? So, what in your mind, or what are the steps that the state has taken, ma'am, from the medication perspective?
See, first in the screening part also, like we are talking of the primary low level. So I would like to share with you that at all our health and wellness centers, we are screening the basic lung, basic cancers, your lung cancer, oral cancer, breast cancer, which are easier, cervical cancer. And this has making a difference in a way, one, the screening is done and the awareness also takes place. Now, another subject which we have so far not touched is the mental health of the patient, the support group they require, the support group that family requires. I would really like to put it out there that, like sir is saying, we need volunteers, we need cancer survivors, college students who can at least share, to put out their mental health. What do they think? It is not easy. It is not only the physical part of the disease, it is the mental state of the patient and the family, which plays a very huge role in the recovery of the patient. So we really need to work on this, that they get this palliative care. Somebody who can't afford, states like Kerala have an excellent palliative care system. We also do. And coming to the government, the state, see, under Ayushman Bharat, I think it is an excellent scheme where the cancer treatment is free. And a major chunk of our patients who cannot afford, simply cannot afford treatment, are taken care of under this. Another good initiative, as is done by Government of Punjab, is that they extend financial help and free treatment to all their cancer patients. You just cannot imagine the sort of support it extends to a patient who cannot even afford to come and take primary treatment at our centers. I think this should be replicated in most our states, and state also should recommend a little more higher financial help to all these. Secondly, a very core subject is that the patient actually is totally at sea at where to go, how to go about it. There is nobody, if even if he reaches a center like PGI, you would really realize nobody is there. We need to have help desks, volunteers especially, who can sit and have counseling for this. Okay, you have this, and this is the outcome. This is the way to go about it. You can get a better outcome and be mentally supportive to that patient. I think if we put all these things in place, we will have a better population which is suffering from cancer at the moment.
Brilliant points, I think. And the last one, I think the sense in, I've done a fair number of interaction on Voice of Health, and I compliment them for the effort they put in to bring these topics out. But this counselor bit that you brought out, Dr. Suman Singh, it comes everywhere, So it comes for mental health, it comes for tuberculosis, it comes for diabetes, it comes for cancer. So I think perhaps at one point one will need what I say from the Health Sector Skills Council's perspective, a job role which it says that we need health counselors. Somebody that you can go and then they show you the path to move forward. Dr. Kovkreja, with your background with the Swedish health system and other countries, do they have health counselors there to assist or facilitate a patient through the journey of care? Do they have something like that?
Yes, Dr. Shabnam, they definitely. So I'll just talk about, in fact, our initiative of Live COE, the Oncology Center of Excellence, which we are talking about.
Yeah.
At AIIMS Jodhpur, we have deployed exactly, so there are 3 ancillary services which we are providing. So currently the cancer patient is getting the chemotherapy, they're getting the radiotherapy, radiation therapy, and they're also getting the surgery. But what they are not getting is the psychosocial support in terms of counseling, psychological counseling, dietary plan, and also ensuring that the patient is passionate and motivated and in a fighting spirit to continue the therapy, don't drop the ball in between. Therefore, they get the outcomes which they actually will get the best outcomes. So we are trying, in fact, as a part of Live COE, we have deployed the counselors and we are studying. In fact, there is a quality of study which is happening as a part of this India-Sweden Healthcare Innovation Center, which will study the impact of providing these services on a quality of life of patient and potentially even the survival, but we are studying quality of life. So of course, the design is already ready. We will be sharing this even on different platforms as well. We strongly believe that this is an important service to the patient which is required. And with the workload which is there, particularly in the academic or even the government institutions, secondary and tertiary care, I think this service is definitely required. Now, coming to, there are countries and there are developed countries where patient navigators play a very important role. So when we say patient navigation, when the patient reaches the hospital, as Dr. Suman Singh was mentioning, right? Is there a help desk? And is there a patient navigator appointed for a group of patients? So his role is only to support the group of patients, and he becomes kind of a support system as an extension arm for the healthcare system, and ensures that the registration is done, the patient is gone to the right unit, because navigating the hospital and the tertiary care center is not easy for the patient. And most of the patients, sometimes they get lost because of that also. There are studies where we have seen that when the patient is prescribed the test, when they go to the laboratory for testing, some of the patients get dropped on the way itself. They don't even go to the lab to get the test done. So how do we ensure that patient navigator navigates the patient through the complexity of healthcare system and ensures that the patient has the right experiences so that he's motivated and inspired that there is all the help available and I'll get the right treatment. So these patient navigators also as an emerging concept, and there are many worldwide, many institutes and the organizations which are having those training programs for the patient navigators as well. Excellent. I think in Tata there is an initiative where they have deployed these patient navigators. I think there is a name to them as well. So it's a very good program. I don't recollect now the name, but definitely it's a good program to start with. Now, do we have such programs across all the centers? I think it's something which we need to really look up to.
Yeah. So when we started Ayushman Bharat, we did a job role called Ayushman Mitra. So basically, but that Ayushman Mitra's job was to sensitize people, rather is to sensitize patient and walk them through the insurance part of it. How do you go put your papers, etc. But from the health perspective, or to walk through like this, I do believe you brought out some excellent points, Dr. Suman and yourself, to take forward out this. So ma'am, when I circle back to 3 pillars, if I were to say, so it is screening, identification, then taking the patient through the value chain of getting diagnosed appropriately, and then finally to get the care which is appropriate. So each one of them, perhaps, each one of these bits requires a policy or protocolization of the entire process so that there will be seamless integration. Like you said, there are some very good case studies in Chandigarh. And Dr. Kukreja, when you finish your study doing the impact analysis in Jodhpur, there'll be learnings from there. What do you think, ma'am, who should be, from a policy perspective, who should drive this? Should individual states drive this, or do you think from the center, from the national grid, it should be driven? Who do you think is the rightful owner to be able to do it and then push this forward? Over to you, Dr. Suman Singh.
See, as I previously mentioned, it has to be a team. Only the state doing it or only the center doing it will not make a So that becomes standalone projects. What I feel is that we should get on one platform the best practices by all the states, cities, institutes, compile them, analyze them, then put them across to all the stakeholders, so that at least if Jodhpur is doing something good or they have opted for something different from what the mainstream is, I think it takes a very small effort to replicate those things at other places also, one being a navigator. So I think what happens is this knowledge is not shared properly. So we actually, what should happen is at they should have at center and state and the private stakeholders at a common platform. They should share their experiences, their best practices, whatever they have been successful in, and they should be shared across with everybody so that we can all together make a great effort and achieve some good outcomes.
So it's sort of coning in that the center should take this up and they should have this platform made, or rather the platform is there. The National Cancer Grid perhaps could be one of the facilitating organizations, but sharing of experiences and then coming up with it would be the way forward. My last question for this session to Dr. Kukreja. The cost of care and the concept of value-based care becomes extremely difficult in emerging economies like India or how do we handle this? I think the most frustrating thing is, at least as practitioners of care, for doctors to know that yes, there is this solution, but a patient cannot afford it, or you know you can write it, but the patient will not be able to access it, right? So where do you draw the line in the availability against the appropriateness of care? How do you tackle this conundrum? Over to you, Dr. Kukreja.
Yeah, I think definitely I'll just build on to what Madam just mentioned, right? Most important is, have we not together solved the COVID pandemic by bringing all the health ministers together, right? As a government took the initiative, they brought all the health ministers, chief ministers together, and we were working on the war footing. Can we take cancer as an example where central government brings all, and I'm sure you have the bright spots and a good examples in our cancer care ecosystem in either the private setups or in the government setups. How do we learn from these examples and really go at a rapid pace and implement these good examples across the healthcare ecosystems so that we are working towards providing equitable access to the, maybe to start with a basic care, move quickly to the optimal care, and then as our respected PM is envisioning that India to be the developed country, I think we also need to have the global standard of care. So how do we move up in the system? And of course, there are ways and mechanisms by which you can, so it is more of a logistic problem. So you need to bring all the stakeholders together, define the responsibilities, create the frameworks, create the policies, so that there is a participative involvement of all the stakeholders to contribute in the fight against this disease. And I'm just taking an example of cancer. It could be similarly for other chronic non-communicable diseases as well. So that we are moving more, and of course, starting with the health and promotion well-being centers, as Madam rightly mentioned, they are contributing significantly. How do we upskill them and expand the scope of work and strengthen them and give them arms and ammunition, and also provide them the hub and spoke model so that they actually navigate the patients to the right centers early on. And just one additional point, I think leveraging technology. We have seen how do you leverage technology in our COVID pandemic, and that learning, I think, is very, very important. Today we have a project where X-rays, if you are screening through artificial intelligence, can detect the early nodules, and potentially a patient can be diagnosed with the lung cancer early. And we all know that if the lung cancer is diagnosed early, your survival outcomes are far better. So leveraging technology and innovations which are happening and deploying in the healthcare sector, and that too creating those pilots, learning from those pilots, and expanding quickly to the different healthcare ecosystems.
Absolutely. Absolutely. So I think on that very promising note of how innovation and AI can be pressed into this, I thank you both for being extremely engaged and providing insights as well as doing. One is providing insights, है ना, सलाहकार बहुत आसान है, but to actually get to do the work and have an impact is a difficult thing. Voice of Healthcare, as always, has its finger on the right spot. I think there are a number of points which have come out from this. And my request to them would be if they can take this forward with their efforts, and perhaps we will come sooner than later into being a developed country as far as cancer is concerned. Thank you all so much for your time, and back to you, Ritika. Thank you.
A very warm welcome, everyone. I, Dr. 𝗕𝗥𝗚𝗗𝗗 on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for our second discussion for today. Voice of Healthcare, along with our supporting partner, AstraZeneca, has taken an initiative to bring together the experts and speakers for this second session of our National Cancer Conclave on the topic Saving Lives via Early Detection, Amplifying Criticality of Timely Screening to nip cancer in the bud. In this session, we will discuss the critical role that timely screening plays in identifying cancer at its earliest stage when it is most treatable and curable. I would like to commence this session by introducing our eminent speakers. So for this discussion, we have Dr. 𝗕𝗥𝗚𝗓𝗓𝗓, Medical Oncologist, Sri Shankara Cancer Hospital and Research Center, Bangalore. Welcome, Dr. Vivek.
Thank you. Thank you.
Dr. 𝗕𝗥𝗚𝗓𝗓𝗓𝗓 Bhotla, Consultant Medical Oncologist and Pediatric Hemato-Oncologist, Care Hospitals, Hyderabad. Welcome, Dr. 𝗕𝗥𝗚𝗓𝗓𝗓.
Yeah, thank
Dr.
you.
Anubha Bathu, Medical Oncologist and Hematologist, Patel Hospital, Jalandhar. Welcome, Dr. Anubha.
Thank you. Thank you for having us.
Dr. Sajjan Rajpurohit, Director and HOD, Medical Oncology, BKL Super Speciality Hospital, Delhi. He will join us in next 5 to 10 minutes. We have Dr. Tamojit Chaudhary, Medical Oncologist, Meherbai Tata Memorial Hospital, Jamshedpur. Welcome, Dr. Chaudhary.
Thank you. Thanks for this opportunity.
Along with sharing his views, Dr. Tamojit will moderate this session for us today. Over to you, Dr. Tamojit.
Thanks. So good afternoon and welcome all to this national platform provided by AstraZeneca. So on the eve of World Cancer Day 2023, we are together. We'll discuss few points regarding the early diagnosis and screening of few most common female cancers, and in that way probably we'll try our best to close the care gap. Thank you and welcome you all. So as we know that although we during our training days or even during our practice we have a lot of theoretical knowledge regarding the cancer screening of breast cancer, cervix cancer, plus minus ovarian cancer, but when we do active practice we can recognize that there is very little practical aspects, particularly when you practice oncology in India. because there is no dedicated or robust screening programs either from the central government initiatives or from the state government initiatives. So there is lots of lacuna to be covered up, and it is very difficult to cover them by our personal efforts. So we'll discuss few aspects and few common aspects and try to give few awareness points also for the general people. So the first question is to Dr. Shainath, that why is early detection very important?
So, I think you have perfectly put the things in perspective. Early detection is very key to improve outcomes. So, the earlier we detect, the lesser will be the treatment related, and the higher will be the chances of survival, and also lesser will be the mortality. So, it has threefold benefit, and it also the other indirect benefits are the reduce in the out-of-pocket expenditure. The patients go back to their normal lives very early and fast, and it's also very low advantages. Early detection is the important key, and
You are not audible very clearly.
And for most contacts. Dr. Tamojit, can you hear me?
Yeah, now it's okay. Please repeat.
Yeah. So is very it will decrease in mortality, cancer, decreased morbidity because the number of treatment modalities will decrease, and importantly,
I think we have lost.
it will be the other advantages of early detection. Am I audible?
Yeah, now it's perfectly audible.
Yeah. So the other advantages are it is like they get back and also they don't on the source of income. So with so many advantages, early detection is very key. And now we do have at least the common cancers, breast, cervical cancer, which can be detected early and which has public importance.
Am I audible clearly?
Yeah. Yes, Dr. Tamojit. I think
Yeah.
he has lost his connection.
Yeah. So, Dr.
Am I audible now? I think.
Yeah, now you are audible. But we can't see your video.
So that's why I switched off my camera.
Perfectly okay.
Yeah. I switched off my camera so that the speed would be better. Yeah.
Yeah. So probably your bandwidth is less. That's why it's not supporting.
Yes.
Perfectly okay. So with an extension to the previous question, so what are the other preventive strategies you usually explain or advocate during your day-to-day practice? So we are aware about the cancer screening, particularly breast and cervical cancer screening. But in regard to these common women cancers, what do you usually commonly say to your patients or their relatives as a preventive strategies?
So most importantly which is now important is, the common cancers. We do suggest, especially the breast and cervical mammograms and pap smear. And we also take this as an opportunity to educate the patient's family about the importance of cancer vaccines, especially the HPV vaccines. That is very important. And also promote healthy lifestyle, taking this as an opportunity to have the family about the decreasing weight, obesity, physical activity. which is, sedentary activity is as good as smoking in terms of the adverse events, and also on the personal habits of the patients like smoking and alcohol intake. So all these have a combined effect as well in prevention of cancer.
Perfect. So very good points were raised by Dr. Sainath, that not only screening is important, not only early going to the oncologist is important, but at the same time, few lifestyle modifications are very important. And one more important point is that till now for cervical cancer prevention, what the vaccines we are using is basically from the Western world. But now there is a recommendation and statement from the Serum Institute of our country, Serum Institute India, that they will make their this HPV vaccines for prevention of cervical cancer, and there is a potential of huge cost reduction for those vaccines, so they will be affordable for the common people, and we should feel proud for that. So the next question is to Dr. Sai Vivek. Hi, Dr. Vivek.
Hi, Dr. Chamojit.
Yeah. So, what are the certain things that one needs to keep in mind to suspect cancer? So, one is not to waste time when these early symptoms arise, and immediately consult the family physician. But for your day-to-day practice, how you educate patients in regard to these common ovarian cancers?
So we have to make it clear to them that depending on which organ the cancer arises from, the symptoms would be following that particular organ. But since we are talking about the most common cancers, especially in women in our country, for example, we clearly tell them that you or anybody else in the future, in your family or your near and dear one, experience a painless and progressive lump in your breast. That is the time you'll have to observe it and bring it to the notice of the healthcare professional. And along with that, also any skin changes or changes in the nipple which are ongoing should be brought to the notice of the concerned doctor. It can either be a family physician at front, then you not come running to the oncologist, but bring it to the notice of a doctor. Similarly, for ovarian cancer, the symptoms are usually not very overt. They tend to have some symptoms of vague abdominal discomfort, disturbance in their normal bowel functions, sometimes bloating of the abdomen. And for cervical cancers, you can have discharge per vaginum, whether it is bloody or white discharge per vaginum, and vague abdominal pain. Apart from these, most of the cancers, whether it is breast, ovary, or cervix, have some constitutional symptoms. If somebody is feeling really weak for a prolonged amount of time, let's say 2 to 3 weeks, they're feeling a lot of fatigue, they're not having enough appetite, and in certain cancers, weight loss is there. These constitutional symptoms are also some things which should alert us to an ongoing problem inside the body. That can be cancer, that can be something else, but these constitutional symptoms and organ specific symptoms are what we clearly need to tell our patients. Probably it might not help them, but once we put it into their head, if somebody else in their family has such symptoms, probably that will lead to an early detection as well.
Perfect. Very well described. So one very important point is that a lot of patients of breast cancer who usually come at very advanced stage to my OPD, or I believe to all of our OPDs, that they say that there is a painless lump and it is gradually progressive, and what we thought that there is no pain, so nothing to be worried. So this is a very wrong concept. There is a very wrong concept. And I used to explain that if there is a pain, the chance of cancer is very minimal.
Yes.
So this point has to be spreaded in a very broad perspective, that slow growing painless lump is the most common symptom of breast cancer, and there is much things to worry if there is a painless slow growing lump in comparison to a painful lump.
Yes.
So very good point raised by Dr. Sai. Yeah, you want to say
all of us. Yeah, and all of us are seeing in our practice that what we have read in our textbooks, that the age of breast cancer is mainly in elderly postmenopausal women. That is actually going away. We are seeing more and more younger women coming with breast cancer. So we really need to advocate this thing of getting a sonomammogram or a mammogram from the age of 35 onwards. And we need to make it a point, we put it in a way that they don't forget it. For example, you do certain things on your birthday. So it should be that you pick a day in a year where that day should be going for a cancer check. So let it be any cancer. One day in 365 days should be spent by almost everybody to go for a small screening so that at least for the rest of the year, you're kind of safe compared to the others.
Yeah, point well taken. Very well taken. Yeah, so unless we are aware and our patients are aware, the relatives are aware, it is very difficult to get rid of this deadly disease. And probably way forward is early detection.
Yes.
Thank you. So next I'll go to Dr. Anuva. Welcome. So for you, I want to ask that what is the role of gynecologist in the early detection with a focus towards these women cancers? So do you think that in your day-to-day practice, the gynecologists are very well aware and they are very well equipped for detection and early reporting and probably early referral to an oncologist for these common women cancers? What is your experience?
So, Dr. Tamojit, I think in our country, especially where there is not a very strong background of patients having a regular physician that they access on a routine basis, gynecologists in our country are actually quite well positioned to promote and spread cancer awareness and implement cancer screening programs. There has to be because first of all, for the patient to go to a doctor, they have to have that relationship. Oftentimes, when they come to us for the first time, they don't really know us. They haven't been seeing us, on a regular basis. But the gynecologist is somebody, especially for women in our country, they have been meeting this person again and again. Oftentimes, it's a family gynecologist, somebody their mother or their aunts have been meeting. So that patient's advice and, will be taken in a better way. So I think, especially for women in our country, gynecologists are well positioned to promote screening programs and implement screening programs and help in early detection of cancer. They not only know the patient, they know the family background, they know the family history. And those for especially cancers of breast, ovarian is quite important. We know that there is a hereditary component. And when you meet the physician again and again, if you may not listen to them the first time, but if they are sending the same message across number of years, ultimately at some point, they will end up undergoing screening for breast cancer. As Dr. Sai rightly mentioned, that in our country, younger women are. So that gynecologist can advise that patient that, this is the correct time for you to get a mammography or get the stool occult blood, get your colonoscopy as you're aging. And implement other tests. So I do think that they are well positioned. I'm not sure that, there was a question about management. I think obviously the management is better done with a multidisciplinary team, but definitely when, there's a gynecological opinion required, of course, they will advise the patient accordingly. But more in promoting cancer awareness and promoting cancer screening in our country and promoting that healthy and preventive lifestyle, which was also mentioned, I think the gynecologists in our country are definitely up to the task of doing this.
Thank you. So point well taken. So if I can summarize your statements, then there are 3 points mainly. So number one is we are not the first point of contact. First point of contact are mostly gynecologists for these women cancers. The second is the doctor-patient bondage is much strong for a gynecologist or for a family physician. And third is probably the way forward. The best solution is a multi-speciality approach, including general physicians, gynecologists, along with oncologists, dedicated medical oncologists, and all other super and subspecialties of oncology. So anything you want to add further?
No, I think you summed it up very well. And I also think one more aspect is for the oncologist to have a good relationship with the gynecologist, and have that feedback where everybody is giving the same message to the patient is very important.
Yeah, so we have to have a very good relation with other super and subspecialties of your branch. Point well taken. Thank you. So I believe Dr. Sajjan still we are waiting for him. Then I'll go again to Dr. Sainath. Am I audible clearly, Dr. Sainath?
Yes.
Thank you.
Yes.
Thank you. So even though there are guidelines on the screening tests, what percentage of women undergo screening? For instance, in Western countries, as we all know, that screening rates are very high because due to a lot of clinical trials, particularly in UK or US, or as a routine government-sponsored approach. So, what is your opinion regarding the status of screening for most common women cancers in our country, and how we can improve the scenario?
So am I audible now? Am I audible? Am I audible, Dr. Tabajit? Am I audible?
You are audible. Please carry on.
Yeah. So if we have to look at the status of screening, it is abysmally low in our country. So if you look at the data, only 1 in 3 women across the India probably has a cervical examination, leave alone having a visual having a VIA or a pap smear done. And if we come to breast cancer, it's almost single digit. The screening rates are in single digit, 4 to 8%. And for the cervical cancer also, that 30% figure is a very highly variable figure, to as low as 5% in some areas to as high as 70% in some areas, depending upon the education, healthcare access. Now, one thing which government can actually do, because these cancers have the screening has a substantial effect on the survival, is to link it to their social security schemes and also insurances and also the healthcare packages. For a government employee, it can make it mandatory that until and unless your family gets screened, we are not going to renew your health cards. The same can be true for the Ayushman Bharat cards. The same can be true for all the insurances, where it is mandatory to have the basic screening tests which will detect the cancer. So I think this would at least begin, and it would gain a widespread popularity, making screening as a prerequisite to having a health cover, and then encouraging people to go for screening, especially cervical cancer and breast cancer, and oral cavity cancer screening, especially for the smokers and tobacco chewers.
Thank you. So, one very important point raised by Dr. Sainath, that it is probably the best approach to increase the coverage of cancer screening by incorporating screening tests in routine health checkups or under insurance, both for the private and government-sponsored insurance. So, among government-sponsored insurances, I think we are having a central government scheme in the name of Ayushman Bharat scheme for cancer treatment. So if screening test can be incorporated as a part of this Ayushman scheme, that's a very good idea. So point well accepted, Dr. Sainath. So anything you want to add regarding other cancer screenings, like for lung cancer or for oral cavity cancer?
Oral cavity cancer is a big problem. Oral cavity cancer is a very big problem in our country because a lot of our population consumes oral tobacco, which is unique. So oral cavity screening by, we have a huge network of dentists, and incorporating them and, encouraging oral cavity cancer screening also helps. So I think we have done one beautiful Kerala oral cancer screening study, which showed despite the flaws in that study, we showed 30% decrease in the mortality with oral cavity screening. So I think that should also be incorporated. Oral cavity cancer screening, cervical cancer screening, and breast cancer screening. These are very important. However, for lung, I think the infrastructure to develop low-dose CT scan is probably a biggest roadblock to have screening in lung.
Agreed. So probably a cost-effective mass screening measure for lung cancer. Low-dose CT is very difficult to implement in our country, keeping in mind the economic structure and healthcare structure of our country. Point well accepted. So for oral cavity cancer, I just want to add that probably before screening, patient awareness and lifestyle modification is also very much important. keeping in mind that more than 90% of oral cancers of our country is either chewable tobacco or smoking tobacco related cancers. Okay, thank you. So next, I'll come again to Dr. Sai Vivek. So almost similar discussion point that in rural India, what actions need to be taken to increase the detection rates, or I'll modify that, early detection rates of common cancers.
Yeah, I think the primary health centers in our country are present. So for the namesake, they're actually well present in most of the rural areas. So there needs to be more training and revamping of these centers to carry out basic tests like a mammogram or a pap smear, or even the healthcare professional need not be a doctor also. So they can go ahead and spread awareness in the villages. It's much more easier and people are more receptive because unlike cities where everybody is like running around, there people can actually be told individually that this is what you have to do. Come in once a year, we will do it for free. And the amount the government will actually be spending on the screening, I feel would be much lesser than what each person would have to be given in case the cancer develops and it progresses to be advanced stage. Yes, it is mass screening. It is going to be expensive, but in the long run, probably that is the way where in a way the government can actually save on the expenditure on cancer treatment for the generations to come. So rural areas, revamping of the primary healthcare centers and the ASHA workers and people who usually go ahead and vaccinate people. So that could be taken as a day. Once somebody goes for pulse polio, they can speak a couple of sentences more about the other women in the house, and that you have these people can go for a screening and get yourself checked. It's completely free of charge. So that way, I think we do have a lot of measures which can be taken up.
Okay, so your opinion regarding doing dedicated screening health camps at regular interval in rural part of our country?
I don't think anybody should go from a urban center and do rural camps. I think that's only temporary, and that is not a long-term solution. We should work towards strengthening our primary health centers where this awareness and screening is done right there. So we do have even mobile mammography units. So one mobile mammography unit can cover, I think, a PHC a day and then cover the population of that area and then go ahead with each PHC. And the same unit can take pap smears also. So pap smear and mammogram, one vehicle the government spends on, and it goes ahead and does all the things in different PHCs.
Yeah, so point well taken. So permanent solution lies in long-term and permanent approaches, not the temporary approaches. Thank you. So then again, I'll come to Dr. Anubha. So very important topic, that what is the genetic testing and its importance in particularly in cancer screening and cancer management in our country. With the focus on female cancers.
So absolutely, we know that as our understanding of cancers and especially hereditary cancers in women such as breast and ovarian is increasing, we know that genetic testing is a tool that we really have to incorporate, and it has an increasing role to play at two levels, I would say. One is to understand the individual's cancer risk, right? So if we know that this is an individual who is at a higher risk for developing hereditary cancer, we can appropriately counsel the patient, we can implement additional screening tests as appropriate, and we can also counsel the patient on preventive aspects and lifestyle modification, and also educate them for their next generation, for their children and their siblings. So that is where it is important to understand through genetic testing what is that individual's cancer risk. The second point, as you rightly raised, Dr. Tamojit, is that there is a therapeutic implication, and that therapeutic implication, as our understanding of cancers is increasing, our scientific knowledge is getting better. We know that there are various cancers where we can give appropriate medications if they have that particular mutation that led to their development. And we've all heard about BRCA1 and 2, not just in breast, but pancreatic and prostate cancers, etc. So definitely, I think more and more patients require genetic testing. And also, I would say that probably as more patients, not just patients, but more people who don't have cancer, who should know their cancer family, the risk of cancer in their family, should know, if the cancer happened at an earlier age in a certain family member, if there are multiple generations. So again, this is something that I think is evolving. Probably as physicians, we also don't know which is the right person to undergo cancer testing, genetic testing. Patients, we obviously advise it, but for somebody who is at an average risk, should that patient be getting genetic testing is a question that I think it's an evolution. We don't know rightly. And that is where the fallacy of these tests arise. Like, if people just go and get this test done, they don't know whether they got it done at an appropriate lab, they don't get appropriate pre and post test counseling, they don't know what to do with the result. And sometimes even physicians, we don't know what to do with that result. So that's why I think genetic testing is something that we really all have to understand a little bit more. There's a lot of psychological impact also of this test. If somebody is they get to know that they are at an increased risk. There can be stress, there can be anxiety. Somebody who gets a normal test, they may have a false sense of security that everything is okay, and they go about, doing inappropriate health acts like smoking and things like that. There is economic impact, because patients can get privacy issues. There may be discrimination in terms of employment or getting health insurance. We don't know how this will evolve in the future. And in the Western countries, they have legal acts which protect patients from, sharing this information. But I don't know really what is the situation of that in our country. So I think this is something that as of yet is something evolving, and we haven't really completely tapped into this tool as yet. But as time goes by, I think it will have an increasing role to play.
Yeah, absolutely. So on this regard, we are still in the learning curve, and the best time is the future for this genetic test and how to implement them in day-to-day practice. So one common problem or dilemma, I should say, that for an oncologist, that you have a particular patient, a particular clinical situation, that this test has to be offered, but patient relatives and patient are not very convinced with your advice. So I am trying to ask you that what are the common barriers for advising genetic tests, and how you try to overcome them in day-to-day practice?
So I think in our country, the biggest barrier is always finances, cost. Not just the cost of the test, but if that test is positive, will we implement with the intervention that is advised? So I think it is at that level that the biggest barrier for patients is, because yes, I know this patient is positive for a particular mutation. Am I going to be able to give that patient the appropriate medicine? So that's the biggest barrier that I have noticed. As we get better insurance, we get better healthcare for our patients, and also probably with government intervention, the price of these medications, get regulated. Probably this will improve in the future, and we will have less problem in convincing the patient that yes, you should get the test, you will get the medicine.
Thank you. Agreed. So one more question to you, that how you do pre-test and post-test counseling during your day-to-day practice. So you take help from a genetic counselor. Is there any dedicated genetic counselor at your center, or you do it by your own, or take help from other fellows?
So I will tell you, I don't think we as oncologists actually get enough training to be very good counselors for getting this genetic testing. And most of the institutions, like I'm in a second-tier city, we don't have genetic counselors in the city. So when I counsel a patient for getting genetic testing, and I tell them that this is, is indicated as based on the cancer that you have, the stage that you have, etc. When I send that test, usually we are partnering with a laboratory, and we are lucky that the laboratory is actually offering pre-test counseling to those patients. So I tend to use that, because I mean, most of the patients will not be able in my city to go and meet a genetic counselor up front. And I don't think that I am the right person to be able to discuss everything in detail and explain to them each and every point what is required?
Yes, so very good point raised by you, that probably we are not trained enough to do a detailed pre-test and post-test counseling. We can do it for the bit, but we are probably not trained enough, and so better to take help from genetic counselors. And again, one important point is that most of the time these genetic labs, including standard or national labs or international labs, they provide this support most of the time by telephonic interviews. Thank you.
Thank you.
So welcome, Dr. Sajjan. I believe I am audible clearly.
Yes, you're audible.
Yes. So welcome to this group. We already had a 30-minute discussion. So I believe we will again add a few important points to this discussion. So what is your take regarding the stigma of or social stigma, I should say, of the commonly diagnosed female cancers in our country? Like most of the time I have patients in my OPD who usually very reluctant to share this information to their common or very close family members also. Like for breast cancer patients, they don't share this information to their sister or mother. So most of the time due to social stigma, particularly who are belonging to the low socioeconomic strata. So what is your experience? What is your take on this aspect, and how you try your best to overcome this during your practice? Am I audible, Dr. Sajjan?
Yes, you're audible. So I got the point. So the most important thing about this, the social stigma is, like for women, it's always more difficult for them to actually first have this acceptance, and the other thing is have social acceptance. And that is why when we counsel the women who have either breast cancer or cervical cancer, so it is a very important aspect of their life. So it means a lot when they have to interact with other ladies in the house or the neighborhood, and then once they interact with them, they have so many questions to ask the same person. So most people would actually like to avoid cancer diagnosis, because many people will have change of behavior of the people either who are very near and close to them. They will start behaving more affectionately. The people who are like at some distance or neighbors might also perceive them differently. Sometimes people feel that they can get acquired this disease just by being in touch with them. So because of the various socio-cultural issues, many women tend to not disclose it, or tend to have a disclosure which is not totally correct. So I think these are the issues which have to be discussed with the family and the person themselves, make them comfortable and confident about the diagnosis, and make sure that they understand the diagnosis, and also how well they are going to take this in their personal life. And I think it's a personal choice to disclose or not to disclose. As doctors, we can just guide them, counsel them, and then based upon their socio-cultural beliefs, it is for them to decide whether to disclose or not to disclose to their family members or the friend. But obviously the family members or the near and dear ones or the people who are the next of the kin, they need to know, but not everybody in the family also need to know. So sometimes it's very important for ladies to have that selective kind of disclosure. And as doctor also, we have to be very importantly understanding of the conversation which we have with these other people, because sometimes the other family members might come and ask you about what is the diagnosis, what do you think about this. So we face many situations in a clinical practice where when the patient is not there in front of us, either the in-laws or the other people might try to ask information about the person, and that's where we need to be very sure as to what kind of information are we releasing, and is the information in sync with the individual who is suffering from cancer.
Yes, absolutely. So we have very good results for removing this stigma, or means increasing awareness, by arranging survivor meets. So that's one of the main strong points I want to convey to all of you, that probably the best person to explain regarding all this disease and what are the treatment process and what are the side effects, what are the duration, everything. I think probably if that is explained by a survivor of breast cancer, survivor of ovary cancer to the patient, even at the hospital premises or at their home, then the reception is much high. they are much more receptive if they are hear all these words from a survivor who herself was a cancer patient once upon a time. So we do regular survivor meets at our hospital. So on this regard, I want to take your opinion, Dr. Sajjan, that what do you think that performing regular survivor
I
meets?
think having survivorship meets as well as people who have already experienced such disease and right now suffering from cancer is an immense value to a person who is dealing with this problem in their life, and also it reassures the family members and the public at large that now cancer is not a taboo and cancer is not a death sentence, and many people are able to cure and live beyond their cancer and forget it in their future life. So I think it's an important message both for clinicians. It helps us a lot when we're trying to counsel new patients to get treatment in the right direction, but it also assures them that no, there have been people before them who have gone through this kind of a situation in their life, how they handle them, and it is kind of a like how humanity has been learning from various innovations or discoveries which have happened in the past. Same way, the fellow human beings keep on evolving and understanding from people who experience things like cancer in the past. So it's of immense value. It's of immense value in a patient's journey, but also of to the clinician and the society at large.
Yes. So we are all aware about the cancer screening tests regarding the screening mammography, when to be started, what are the high risk situations, pap smear screening for cervical cancer. But unfortunately, there is no structured screening or population based mass screening in our country. So what is the best way forward as per your opinion?
So I think,
to overcome
this? The mainstream media can have an important role, and then the government could have initiatives where they could make it as a part of, like we have universal immunization program for children. So such kind of initiative on the part of the government can have a huge push into these programs where people are aware about their lifetime risk and they are able to go through these programs where a screening could be made possible for all the individuals in the country. So that's one thing. At individual level, doctors also have to need to have this promotion of these screening programs doing whenever they are going for health camps or cancer awareness checkups programs. There it can be promoted. So it requires continuous effort both on the part of individual doctors and also on the part of the policymakers to make sure that these programs are adopted by the general public.
Yes. So the next question is, what are the regarding the newer technical advances in cancer screening for breast cancer particularly? Do you commonly use in your practice any newer techniques like newer modalities for like mammography, 3D mammography?
Yeah,
like that?
so mammography, I have used thermal mammography in my camps now. Of late, I've been using it, like 3 camps I've done with thermal mammogram. And I found that it's more comfortable for the patients. I don't know how much accurate it is, but I assume that it might be at least sensitivity might be good, specificity might be low, but then it might emerge to be a good non-touch way to do thermal mammograms and do some population-based screening based. Also, it is attached with AI, so AI could also have a role in making these accessible to wider population, because otherwise normal digital mammograms are difficult to deliver to large population and also difficult to carry, and they can have logistic issues. So newer techniques like ultrasonograms, hand-hold sonomammograms or thermal mammograms might have an important role in the future.
Yes.
Dr. Tamajit, can I add something here that I recently was exploring? So what I found, which it's not into the mainstream right now, but I think probably in the next few years, something that should come up would be that multi-cancer early detection test, which is, I mean, the idea of that test is very exciting because it's a simple blood test. And, you know, if we have a simple blood test that gives a signal that this is somebody who has to be investigated a little bit more, and oftentimes there are many cancers which we cannot screen for, right? Like we only have certain cancers that we can screen for, but we know that the mortality with the other cancers is actually higher and they get detected later. So this simple blood test, which could give that signal that, you know, pick up this patient and have them undergo additional testing, I think probably in the next few years, that would be something that would come up.
Yes, absolutely. So lot of investigations and trials are ongoing. But as of now, for a population-based mass screening, we have very few tests which are approved. And one thing that Dr. Sajjan raised, that thermal mammography, it is also no-touch procedure and very easy to implement as a mass screening procedure. So point well taken. Thank you. So I think we have already come to the end of this discussion. And last part is just a one-liner summary from all of you, which you want to convey to the general population on the eve of World Cancer Day this year. So I'll start with Dr. Sainath. Are you here, Dr. Sainath? Then Dr. Sai. Dr. Sai Vivek.
Hi, Dr. Tamaljeet. I think Dr. Sainath and Dr. Sai Vivek has to go to an emergency. And Dr. Sajjan also left due to some emergency patient. So Dr. Anubha is there.
Okay. Okay. So
Okay.
Dr. Anuva.
Yeah.
Yeah.
Sure. Thank you so much. I think all the points are very well taken that all of our esteemed panelists said, and as you summed everything up very, very well and very succinctly. What I have to say is I think on the eve of World Cancer Day, basically knowledge is power. So let's spread cancer awareness. Let's promote early detection, and let's empower our public. Let's empower our society by spreading cancer awareness. That's what I would say.
Thank you. Thank you.
A very warm welcome. I, Dr. 𝗕𝗥𝗚𝗚𝗓𝗓 on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for our third discussion for today. Voice of Healthcare, along with our supporting partner AstraZeneca, has taken an initiative to bring together the experts and speakers for this session of our National Cancer Conclave on the topic Scope of Synergy, Current Challenges, and Scope of Intervention for Existing Infrastructure of Healthcare for Cancer Care. I would like to commence this session by introducing our eminent speakers. So, for this discussion, we have Dr. Shabnam Singh, Principal Advisor, Health CII. Welcome, Dr. Singh.
Thank you for the invitation, Ritika. Very happy to be here.
Thank you, ma'am. Dr. Pragya Shukla, Head of Department, Clinical Oncology, Delhi State Cancer Institute. Welcome, Dr. Shukla. Mr. Sanjay Seth, ex-VP, IFCO Tokyo General Insurance. Welcome, Mr. Seth.
Thank you very much, Dr. Ritika. A pleasure being here, more so on the occasion when you are having the International Cancer Day tomorrow, a very important subject being talked about.
Yes, sir. Yes, sir. Dr. Santosh Devdas, Medical Oncologist, HCG Cancer Institute, Bangalore. Welcome, Dr. Devdas. Dr. Arun Chandrasekhan, Consultant Medical Oncology, Esther MIMS, Calicut. Along with sharing his views, Dr. Arun will moderate this session for us today. Welcome, Dr. Chandrasekhar.
Thank you, Dr. Ritika. Thank you for the
Over
invite.
to you. Over to you, sir.
Yeah. Okay. Thank you to Voice of Healthcare and partnered with AstraZeneca. We have a very important day coming up tomorrow, which is the World Cancer Day. And the main motto this time is to close the cancer care gap. So today we have an eminent team of panelists who will be sharing their views about how to close this cancer care gap and what is their message on the World Cancer Day. So I was asked to moderate this, I think 1 or 2 days back. So I'll just be, probably asking questions for a few inputs in, but we have our experts on, the dais who will be sharing their experiences. So the topic is the current challenges and scope of intervention for existing infrastructure of healthcare for cancer care. So those are big words, but I think we'll try to make it as simple as possible. We have close to 1 hour. I'd like the organizers to let us know. We most probably should finish ahead of time, but if you're running short, please do let us know. So I'll address the first question to Dr. Pragya, who's from the Delhi Cancer Center, Delhi Cancer Institute in Delhi. Question to you, ma'am. How can the existing infrastructure be strengthened to improve the early detection and diagnosis of cancer in India? Like, are we doing enough for cancer screening as of now in India? Is there some statewide disparity, you think? And do you think we need to do much better?
Obviously, there's a lot of scope for improvement. We are not doing enough. That I would say, and that's a sad thing. Unfortunate thing that we are not. I have to say that, but that's a fact. What I personally feel is the awareness should start from school level. So in school, I think there should be orientation programs. Oncologists can be called there. I have myself volunteered in my son's school, and every year I present once a talk, and it is in Hindi on different types of cancer and what are the signs and symptoms and how we can prevent them. I talk about cancer vaccines and also about the myths associated with cancer. So I try to bust those myths. So one is this. Second is that we are waiting for the people to come to oncology setups or to healthcare setups to come for screening, to come asking about information about cancer. And so what is happening is that people are not approaching the hospitals, the cancer hospitals, because in India, most of the people, it's difficult, the time is going to earn their bread and butter. So they don't have time to come and approach the institutes for information. So whatever information or whatever curiosity they are having, it's mostly being answered by hearsay or some Google or some YouTube or something like they come across with. So I personally feel that the government of India and the state governments will have to take up, the owners will have to come upon them to, rather than people coming and approaching us, waiting for the people to come and approach us for information, we go to the people. So in that direction, some NGOs have started having this cancer screening vans. So I feel that this should be a part of the district health program, cancer screening vans. So rather than people coming up to us, I hardly see people coming for screening, So it's better that the vans approach the villages, the panchayat house, they can have a tie-up with the panchayat of each village, and they can have orientation talk, and so various like Inner Wheel, Rotary, IMA, all these people are can be roped in, and we can have they can adopt a village the IMA or the Rotary or the Inner Wheel, Lions can adopt a village, and then the screening of that village is being taken care of by that particular body. And then people who have any suspicious finding are then brought, and it's not just like, no, what I'm seeing is most of the screening programs are just photo ops. So they have this social media and selfie opportunities that they get, and they click pictures, post it, and then forget about it. So what about those people who actually test positive or have some suspicious symptoms?
Hello, ma'am. I think it's
It
the
requires
oh yeah.
requisite treatment is given to the person who has been detected suspicious. So this. Second is even after the treatment finishes, what happens is we wait for the patients to come for follow-ups. So, and then what happens is primarily center like ours, Delhi State Cancer Institute, we are flooded by people who are coming either in an advanced stage, or if they are coming for follow-up, or they are lost to follow-up, and then they come back when the recurrence has come and the disease is totally out of control. So if we have these vans or bodies who are going the importance of screening, follow-up, follow-up of cancer survivors. So so it's a very big thing, major chunk of population can be catered to this ways. Then what I feel that we are underutilizing our ASHA workers. So the grassroots workers, they are the ones, the villagers or people in small towns and cities, they are more close to, they are the ones, they tell about their issues, their problems. So I think we have to involve the ASHA workers who teach females breast self-examination. They teach the population by large about early signs, early symptoms, and what should be reported and how it should be avoided, how it can be prevented, cancer can be prevented. So that thing is there. Then what I feel is the availability of tobacco and alcohol. Something has to be done to restrict the easy availability of tobacco and alcohol in this country. So I can see tobacco being they are being sold as a Kurkure packets. So when I am sitting in an institute which is surrounded by, I think, 6 big hospitals and a number of schools, and here at every 10 steps you have a gutka seller, supari seller. So Zuba Kesri is all over. So these things are which we have to really fight aggressively. And when I say aggressively, I mean that I'm not that inhuman that I don't understand that tobacco is also the bread and butter of a lot of people. But bread of butter can be drugs also. Selling drugs, will you allow that? No. So there are so many things. Bread and butter can be selling arms, selling so many bad things. So we have to suggest, give some alternative source of income. So you have to tell them the alternative cash crops that can be sold rather than cultivating tobacco. Why can't they cultivate other crops? Why can't alternative ways of income earning be generated for those people who are earning their livelihood right now with tobacco or tobacco associated industries? So the gutka kings are reigning supreme. Everywhere the gutka kings are reigning supreme. This belt from where I come, Bundelkhand, So the whole belt, Bundelkhand, Urai, Kanpur, all it is like no, even small kids, 8 years, you'll be shocked. 8-year kids are chewing gutka, and these people take immense pride in telling ki, "Arey, wo to 8 saal ka moda bhi gutka khata hai uska." They take immense pride as a like no, they're getting some Olympic gold medal at the age of 8 years. So this thing really shatters me, and when I say this, people think that I'm being too aggressive. No, if I demand 100, I will get somewhere around 80. If I say a total ban on tobacco free India, I will be somewhere around 80. They say that if you go for tobacco free India, you go for ban across tobacco selling and tobacco production, it will be done in black market. So what are the policymakers and law enforcement people there for? Just because a black market or a parallel market will come up, you will allow that thing to go on, allow people to sell poison. My 9-year-old son tells me, if Mama, you keep telling me tobacco is very bad for health, alcohol is very bad for health. He said, why does government uncle allow these things to be made? So he is asking government uncle why this thing is being allowed to made in the country. We come from any international flight or the terminal is flooded with what you call duty free alcohol. Is alcohol required to be made duty free? My question is this. This is an item of luxury. This is an item of poison. This any amount and any type of alcohol, mind you, and I say it in bold, is harmful to the health. The myth that certain white wine and red wine or certain amount is good for cardiac thing, it is all a myth. So
I'll have to interject a little.
No, I become very passionate.
Passionate. I could understand that. I think the issues are quite deep rooted. It's going to take all of us, I would say, to make a positive impact per se. Yeah, there is the part where the government also has to step in and along with us, and the people's attitude also has to change towards it. Just one small question regarding to screening. As you said, you'll be reaching the patients. You have those vans which can do screening. Which 3 cancers would you prefer screening in our Indian population? Which you would recommend?
If I see the incidence wise, so in females it's cervical cancer and breast cancer. Okay, and these can easily be screened, and they can be caught early, and the van can also have now that India has come up with the vaccination, our own vaccination. So these vans can also have the vaccines available, which can be given to the girls right away as they are brought to their doorstep, the screening vans. For males, oral cancer can always be screened in those vans. For elderly population, PSA can always be PSA can be tested, prostate can be done with. So, and even if they come with signs and symptoms, if somebody is a chronic smoker and is coming up with coughing and all that, so at least they can go for chest, for lung examination. So when you do it, then you get to know what all things can be added.
Okay, ma'am. Thank you for that input. I'll be coming back later. I'll move on quickly to the next question, and this is to Dr. Santosh. What are your suggestions on how we can lessen the gap between identification of cancer symptoms to diagnosis to initiation of treatment? Dr. Santosh? Has he joined
I think
us?
no, actually he joined, but there is some issue with his laptop, so he's not there. But I'll ask him to join.
I think
In the meantime,
Dr.
he can ask.
Santosh has not joined the session.
He has joined, but due to some issues with his internet and laptop, so I think he had to leave. So we can move forward to the other speakers. Yes.
Or should we come back to it later? I think we'll come back to it later. Yeah. Okay. In case he joins us. So the next question to Dr. Shubhnam Singh. how do you feel the COVID-19 pandemic has affected healthcare infrastructure in India, particularly related to cancer? So, were there any positives, and and what were the negatives as well?
Sure. So undoubtedly, the number of beds which were allocated for COVID care, they were sequestered for oncology, were sequestered for COVID care. And likewise, the doctors, nurses, and the entire healthcare service delivery system was geared towards COVID. There was approximately a 54% decrease in the number of new registrations. So not only was the infrastructure not available for utilization, but patients also were not able to access it because of the successive lockdowns, right? Then the second challenge that was there was that this particular piece occurred mostly in tier 1. Tier 2, tier 3 in any case has limited number of beds as well as doctors for onco services. So they were marginally affected, but it was the impact was maximally felt at tier 1. In radiotherapy, the uptake and the continuum of care for radiotherapy was not that badly affected. It fell to about 25%. But interestingly, while all this, the new registrations, the screening processes, all were stalled, and the impact of this is only going to come out in later days as to this discontinuing the care, how is it going to affect the longevity or the mortality as far as patients are concerned. Some positives have also come out of this. Number one being the understanding that people, when they needed care, they wanted something very close to their house. So earlier they would always rush to the larger cities, the larger cancer care centers. But now there is an opportunity for them to be closer to home, and they will accept it. They won't run to the large ones at the drop of a hat. That's one. Second is it lends itself to teleconsults in a nice way. So they are accepting of taking the advice over a teleconsult in a very positive manner. And the third thing is that the general concept of public health strengthening for all levels of care has now come in, and it's seeped into the states also taking up and saying, no, we also have to take care of our people. So there, both sides of the coin that are there. Lastly, an interesting thing has evolved that now people, while they are providing care, have realized that you need to get them in fast, and you need to turn it around. So then the value concept of value-based care, instead of asking them to get a whole gamut of tests and then coming, they are sort of looking at treatment guidelines in which the value sense of value-based care is coming up, and therefore perhaps, fingers crossed, it will be more affordable. Back to you, Dr. Arun.
Thank you, ma'am. Excellent points. I hope my voice is not echoing. It's echoing quite badly here.
No, it's
anyway,
good.
It's okay, right?
Yeah.
Okay. The one extra point which we have seen in practice is because of the increased amount of scans being done, we had an increase of early. So there were quite a few patients, lung leak, because they do CT scans for COVID, and then they detected quite early in surgery. And our cases of stage 1, stage 2 lung cancer detection went up. Now it's back to normal again, but that's just, thought. Okay. We'll move on to the next question. This is to Mr. Sanjay Seth. We know that insurance penetration is quite less in India. What can be done? Do you think there's a disparity in Tier 1, Tier 2, Tier 3 cities? And how can we get better penetrance of medical insurance so that everyone can afford excellent healthcare.
Thank you. Well, you are very right. The insurance penetration is definitely pretty low in our country, in spite of the fact that in the last 2 decades, it has gone up from a 2.7% to a 4.2%, but still the numbers are insignificant. Now, of course, what to do to improve it? Well, as a first measure, I would like to mention that insurance, in spite of all the efforts or all the awareness campaigns which may have been launched over the years, is still not an option to be purchased. It has to be forced and sold to the buyers, which itself means that either the awareness towards insurance benefits is very poor, or the confidence and conviction in insurance making good the losses when the need arises is not that very high amongst the customers. Added to that is also an issue which is more relating to the mindset, I may say. We are not going to face a situation where we will be requiring the benefits of insurance. A very fallacious approach and thought process, I feel. Things are so uncertain, life is so uncertain, and medical treatment costs are so prohibitive now. To think that nothing will go wrong with me or ours is definitely not the way to go about it. Yes, to some extent, the employers, they have taken care of the employees, wherein they take insurances for the group of employees that they have, and those people are covered. The government has also come up in the state level, central level to provide insurances to the masses, but the sum insureds are relatively low there. Most important segment which has to be into the fold and net is the individual insureds, where, of course, the numbers are very, very low. People feel that it's a lot of cost burden on their pockets. A large number of population, of course, as you mentioned, is in our country still residing in tier 2 and tier 3 cities, where the penetration has been low on account of various factors, one of which is definitely the fact that the viability and the cost economics does not work out for the insurers, because the takers are so very few and their paying capacity is also so very limited that they may not be in a position to shell out the insurance premium amount comfortably. Also, of course, insurance, except maybe to a limited extent in case of motor third party, there is no necessity or compulsion or mandate in our country to take insurance. So it's basically at the comfort, convenience, and desire of the person that he or she desires or opts to take insurance. Being centered towards the urban centers, very obviously where the paying capacity exists, you can't have wider penetration because India still resides in tier 2 and tier 3. Now, what can be done to improve this situation? Definitely, there is need to increase the insurance awareness amongst the masses. Just as Dr. Pragya said, there is need to increase the awareness about cancer amongst the people. There is also need to educate people about the possibilities which may give them some financial support in case some dreaded disease like cancer hits any member of their family. A lot of people are not taking insurance because they feel the claims will not be paid when they are raised. I think that is again a very ill-conceived notion. Most of the claims are paid out by the insurance companies. It's a very small percentage which is not paid out. And of course, there are reasons behind those payments not being made. So one has to understand the policy terms, conditions, exclusions, exceptions, limitations within which the payments can be made and will be made, and they are made. The other reason perhaps could be that a lot of people feel this is a cover which will only be paying in case I or any member of my family is hospitalized for treatment. And most of the time, that is not the situation. So why should we buy insurance? Most of the times we go to the doctor next door, take medication. We are fine after a week or maybe 5 days or whatever it is. And that cost is definitely on our pocket. So we don't get whatever we spend. We only get very limited, so to say, reimbursements when a problem arises or occurs. Nonetheless, the fact is that when the problem arises and occurs, it makes a huge financial drain on the pocket, besides the mental and physical trauma to the patient. So it is definitely a need for an all-out attempt on the side of the government, the insurance industry, and also the people in general to understand the need and the availability of insurance and the purpose behind insurance. To make it happen, I think steps have been taken all through. The government, the insurance industry, the IRDA, they are all alive to this requirement. I'm sure just as the penetration has increased in the last 2 decades, it will continue to go up. And with the younger generation now opting for insurance of their own volition, I feel in the years to come, this problem per se, which is pretty huge today, will definitely be lessened to a great extent, if not totally eliminated. Thank you.
Thank you, sir. I think excellent points made. One quick follow-up question. What would you advise would be the ideal amount of insurance for a middle-class person? It's a highly subjective question, but somebody in the middle class, at least this much would be good to cover things.
If, I am surrounded by all doctors in this panel and medicos, if I may not be badgered, I think it's a better question to be addressed by the hospitals and the medicos, because the cost of treatment is determined by the hospitals, not by insurers. However, having said that, see, the cost of treatment is so heavy, and of course, it's prolonged treatment, which is necessary in case of, critical illnesses, particularly, say, cancer. The annual limit at this stage, I feel, in any case, though even that is not found sustainable at times, I think anyone should start with a basic cover of 5 to 10 lakhs at least, and there are options available to top up the cover, wherein you pay lesser premium for the higher value of sum insured, because the first layer, which is say 5 lakhs or 10 lakhs, whatever option you take, attracts higher premium, and a lot of claims get settled within that burning layer of the amount of policy. So if you create a policy of say a 5 lakh today and take a top-up cover of 25 lakhs, which means the first 5 lakhs will not be borne by the top-up insurer. However, you are standing covered to the total extent of 25 lakhs. And this differential top-up cover comes at a very low premium cost, vis-a-vis the first burning layer of say 5 lakhs, which you opt for. So I would definitely feel that on an average for a middle class, that too for a family group, because floater policies are available, somehow or the other, one should try to look at an overall protection to the extent of 20 to 25 lakhs today, considering the cost of treatment. God forbid if there is more than one necessity for hospitalization in a calendar year or a financial year or the policy year, there are possibilities to replenish the sum insured again, but on the face of it, something in the vicinity of 20 lakhs, I think, should be looked at.
Thank you, sir. I think that's a good point per se. When it comes to oncology, especially as a medical oncologist, we have drugs, which range a single dose from 1.5 to 2 lakhs. Not all of them are required, but there are certain drugs which do make a difference. Like in lung cancer, we use oral targeted therapy costs around 1.3 lakhs per month. But I think we'll come to that question later, where you have oral targeted therapy, which is not covered by insurances. So for cancer, I think the coverage is taking it as high as possible would, as your limits allow, would be good. So we'll move on to the next question, and we have Dr. Pragya again. So how do you address the emotional and psychological needs of patients and provide support just beyond medical treatment? So the question is like, do you spend extra time with the patient, or do you have a social support or some kind of social workers who help you out with this? Over to you, ma'am.
Yeah. See, cancer will persecute the person. Yeah. So the main cause of cancer is lethal, and in this country, cancer sadly has been associated with the death sentence. My voice is.
Hello, ma'am.
You're losing you.
I think you're not audible.
Pardon? What are you saying?
We were not able to hear you intermittently. Now I think if you can continue again.
I think there's some network issues.
Yeah,
Maybe if you switch off the video, it might work better.
Yeah, let's see. Yeah, it's better.
Yeah.
Care, and that does not mean only the doctor, especially in normal setup like us. I don't think it's going properly. Should I leave and come back?
It's still breaking up, ma'am.
That is what I'm asking. Should I leave and run back?
Okay, I think some network issues, so we'll move on to the next question till ma'am gets back. The next question was, okay, yes, ma'am.
Yeah.
Can
Is
continue.
it okay now?
Yeah, it's perfect.
Perfect. So what happens is in a government busy setup like ours, in a government setup like ours, the interaction of the patients with the doctors is very little. So we are just there. We are writing the medications and telling them about the disease, but the aspect of emotional support is not that much there as it should be. So herein comes people which are associated with us, and that includes everyone. Be it the nursing orderly, be it the nurses, everybody comes into the picture. And in our setup, I have realized that the patients are more open and more close to the nurses, because it's the majority of the time they are staying with the nurses, be it in the wards or while the chemotherapy is being administered. So these people are with them a lot. So that is why I have got my nurses trained how to deal and how to counsel patients, and how to show them the positive results of cancer, like tell them loud and clear that all cancers are not death sentences. So there are people who get cured, and a lot of cancers are curable. So, and you don't have to see the result of other people, because each cancer is different, and even with the site, even if the site is same, then also the cancer is different for everybody, because the molecular genetics is different in each person. So that is how I'm going about in my institute. We have had a 21-day training program for our sisters, and wherein they were like in small groups. They were trained how to tackle these emotional issues and emotional support aspect of the patients that they come across. Then what I want to say is I am very active on Twitter. I'm very active on Facebook. So every time my handle, I will, like a morning, I will tweet something positive about cancer. some information about cancer. I will at least RT things up from cancer patients who are doing well, so that the message goes through my handle that cancer has positivity attached to it as well. And now we are having positive results. We are having people who are surviving in spite and despite cancer. And every forum I go to, I tell them that the entire research right now in oncology is into either cure cancer, and if not able to cure it, at least make it a chronic disease like diabetes and hypertension. So what if we have got cancer? We can live with it, and like we can live with diabetes, we can live with hypertension. Why not? We can live with cancer also, because there are n number of drugs which will give us longevity. And this I request on every forum. I request media, I request Bollywood with folded hands. Please don't sell tears in cancers. Sell happiness, sell longevity, sell success with cancer treatment. So because we have to put across that cancer patients are cured, cancer patients do have a life even after being diagnosed of cancer. That was, I really appreciate Mahima Chaudhary. She got herself diagnosed for cancer. She got herself treated for cancer in the country. And then she came and told everyone that now I've conquered cancer and I got it treated in the country. We have people who have, with no disrespect to anyone, but we have had celebrities who have had cancer. They have hidden that they were having cancer. And then even if they somehow the things got out in the social circle, they went abroad and got it treated. So what the message that went to the common people is that अगर आपके पास इतना पैसा है कि आप अमेरिका में जाके अपना इलाज करा सकते हैं, तब तो भैया आप बच जाएंगे. नहीं तो आपको कैंसर हो गया तो then you are finished. So I want to say it loud and clear at this forum. I am from Tata Memorial and I have represented the country at international forums a number of times, and I have got standing ovations for the studies that I have presented, and we are at par with the best in the world. What is treatable there is treatable here. What cannot be cured here cannot be cured there also. So it is adequate treatment at the right time that is imperative, and this has to be spread across. Thank you.
Thank you, ma'am. As you mentioned, when I was in TMH in my training times, and the system they had there in the lung cancer OPD, every patient by the consultant was sent to the medical social worker's room. So if you forget to send it, you hold it by the consultant. Each patient has to, and they have a stamp on the file stating that they met the social worker. So Dr. Kumar was very particular about that, and I think it made a huge impact because the patient's fallout rate or the follow-up was much more better. They were counseled in a way that do not worry about cancer. So I think it's a very good thing that, as you've done, ma'am, training the staff to help you out. It's definitely should be done by every hospital in the country. We'll move on to the next question. This is to Dr. Sanjay. Mr. Sanjay. Sorry, again. This is regarding the insurance coverage of oral therapy. As you said before, there are certain drugs which are very life-saving, but they are oral therapy. You have survival from which has improved from 6 to 10 months, and now people are surviving more than 3-4 years on alone. Most of them get rejected by companies. Also, with regards to immunotherapy, targeted therapy, those therapies which do not use the word chemo in them, they kind of get rejected. We had personal experiences with that. I think things are getting better, but what more can be done? And is there a reason why the rejections happen?
Well, of course, you very rightly said there were a certain exclusions which have been placed within the insurance policies, and all these years, quite a few types of treatments could not be paid out against insurance policies under insurance claims. However, insurance is still as is treatment in an evolutionary stage, and things are changing every other day. The discomfort of the insureds and the patients in particular was definitely pinching and painful to the insurers also, but in the absence of a lot of data availability and the costs likely to be incurred, the premium pricing was a very big challenge at that stage. And you would definitely appreciate, doctor, when a new therapy or a new drug is introduced, the costs are so very high that maybe a couple of claims can also definitely rock the boat in a very bad manner. So there were exclusions, no doubt, but with the change in the medication system, the insurers also have been now in bringing in the change to their policies exclusions, and the regulator, the IRDAI, has also been alive to this from time to time. Ever since 2012, 2013, I very distinctly recall, IRDA has been very insistent on bringing about a lot of health regulation changes in terms of insurances. And quite recently, it's not that recent, but then it was sometime in the year 1920, when the IRDA, in keeping with the advances in the medical treatment and the new therapies and availability of medications, they have instructed the insurers that hitherto a certain exclusions would now not be operational. And one of them was the oral chemotherapy treatment given for cancer patients. You may be definitely aware that even in some years back, till very recently, of course, even robotic arm surgery was not being paid out against the insurance policies claims. All these things have changed gradually, and they are changing for the better. You did mention that where the terminology chemotherapy does not come into play, the claims are not considered. Well, those are therapies or treatments necessary for cancer, but there are so many other things which are also coming about. No doubt, gradually they are getting medical acceptability. Medical science has accepted or demonstrated their utility or their, purposefulness. Nonetheless, as I said, certain things do take a certain time to come into practice and usage. Gradually, as I said, chemotherapy on the oral medication side has been now considered to be paid within the policy ambit. Gradually, some other therapies will also be coming into the picture. Sooner, I hope, rather than later. It is the interest of the patient and the insured, which is definitely going to be taken care of. And with more data availability, I am sure these things will be considered as covers rather than exclusions, as have been the case today.
Thank you, sir. As you said, that term chemotherapy is something that even we as doctors have, started not using. It kind of scares the patients. So, we kind of say different new forms of therapy. And with the advances, there are many diseases where chemotherapy has been replaced by targeted therapy and immunotherapy. You don't need chemotherapy with all its side effects. But if you actually look at the etymology of chemo means any drug which you give a patient, which would include everything. But as I said, I faced more of these hurdles around probably around 2-3 years back. Right now, most of the insurances are covering most of the targeted therapy within a scope. If it's outrageously expensive, obviously it's going to be difficult.
True. And of course, you would also appreciate that there is an expectation or demand for insurance to be made cheaper. With expensive treatment, it will be very difficult to make insurance cheaper. And that insurance becoming cheaper would be an important aspect for a wider coverage being available or penetration being available. So it's a sort of a difficult situation. It has to be a very balanced approach which will have to be taken. And yes, I am with you that all sorts of therapies wherein the treatment is beneficial to the patient should be brought within the ambit, yes, with some study, research, and costing.
Okay, thank you, sir. Moving on to the next question. This is to Dr. Shubhnam Singh. What do you think are the current challenges in adopting innovative treatment options and diagnostics in India? How can it be overcome?
I think what Mr. Seth and what you have been discussing essentially is pointing to the why of it. I think the challenge today with Ayushman Bharat successively having taken care of the bottom of the pyramid, we have a very large chunk of the missing middle, as we call it, the 1/3, right? That is a self-employed person, the professional. How do you reach out to them to be able to bring them into the ambit of insurance, right? And when you bring them into the ambit of insurance, then the risk is spread out. And when the risk is spread out, that is how the affordability will come in, right? That's point number one. Point number two is something what you mentioned, Dr. Arun, the new lines of treatment, right? Whether it's T-cell therapy, whether it's targeted therapy, whichever way you look at it. It's not that it's required by everybody, right? But when you do need it, it should be available at a cost which is covered by your insurance. Individuals will never be able to cover it to the extent that is required, right? And in insurance, it depends upon who pays for it, whether the government pays for it, whether you tell the employer to pay for it through group insurances. I believe we are just scratching the surface of insuring our people. The penetration is dismally low. We really need to put the pedal on it. Only then will affordability come into the story of cancer care. At best today, if we focus with a hand to our heart on screening, picking them up early and having the right set of diagnostics to be able to support that screening purpose, we will be in a good place, and thereby the initial medication that is required, which is not so expensive, will be pressed into use till we are able to get through the insurance piece. Back to you.
Yeah. Thank you, ma'am. I think those are good points. We also have the companies that launch these innovative products. There's special price for what is being sold in Europe or in USA for that matter. What they charge in India is almost, I think, around 30% of the cost per se. So they are helping, but still 30% is a big amount per se. But at least, things are getting better. We have our very strong India pharma industry, which are very good at making good generics. So we've recently had a drug which was largely being imported, which was around 75,000 per month. And once the patent expired, then next day 7 launched that same for 3,500 per month. So the patients were absolutely happy, and I was absolutely happy. There were patients who I was, waiting to use this therapy just because of cost I couldn't, but then I could, start the next day on January 11th, and things were getting better. Yeah. I think we've finished. We have 2 questions which we are supposed to read to Dr. Santosh. It's almost 5 o'clock. Can I ask the organizers, should we take those 2 questions? It will be to Dr. Pragya.
Yes, you can ask Dr. Pragya those questions because Dr. Santosh
Ritika?
couldn't join. Yes.
Do we have time, or shall
Yes, we have time.
close?
You can ask this question to Dr. Pragya. And yes, Dr. Santosh will not be able to join.
Yes, tell me. I'm ready.
Okay. Dr. Ritika, we can go ahead.
Yes, sure, Dr. Arun. You don't need any permission to.
I think that's a yes, right?
Yes.
Yeah, so to Dr. Pragya, We've this was supposed to be to Dr. Santosh. How can we lessen the gap between identification of cancer symptoms to diagnosis to initiation of treatment? Like where is this? Why is this gap happening? The patients who have a symptom, they don't show. Then after that, they prescribe tests and they fall out of follow up and such. So how do you improve on that?
That is what I keep reiterating. The message has to go loud and clear that cancer is curable. And all cancers are not same. Every cancer is different. And this cancer of the same site in two individuals are different. And then we have to make it very clear that cancer is, what I said, is not a death sentence. And I think once people are able to get over the taboo that is associated with the diagnosis of cancer, they will reach out for treatment as soon as they get to know of the diagnosis. Right now, what is happening is they have it that as soon as it is diagnosed, they just surrender, thinking that now nothing can be done because there is no cure for cancer. So, and ilaj bahut mehenga hai. Then there's a lot of toxicity associated, because all our movies and all our serials have shown people losing hair and vomiting and skin turning black. So they have, painted a very grim picture of the treatment associated with cancer, which is not so with the modern drugs and the modern treatment machines that we have in radiation oncology and the drugs that are now available for chemo and immunotherapy. So the message, the framing of the message has to be, with a lot of sensitivity. So that sensitivity is lacking, and we are, what I keep saying, we are trying to sell tears. We have to sell success stories, and therein the media and the Bollywood has a lot of role to play.
Thank you, ma'am. Very, very apt words, exactly. Cancer should be looked at as, not as but with an eye of, be a little empathy, but, definitely as a victory for a patient, as they go through it. The last question, I think it was supposed to be for Dr. Santosh, and because he's in the private practice per se. Ma'am, your thoughts on the same question. Like, what challenges do you have treating patients with insurance coverage? I think in Delhi Cancer Institute, patients without cancer coverage. What issues do you? What impact does it have?
So, I would like to say that at least in the government setup, there is no dearth of funds. It is the dearth of intent, which is hampering the progress and the availability of latest treatment drugs and machines for the patients. So for me, it is a fight that till I'm able to get the recommended treatment to the poorest of the poor, I will always find myself to be a failure. So this, I am doing my best what I can do to, change mindsets, that we need to give the best of the treatment when government is ready to pay for it. So government is not stopping us. So it's just the people who are working for the government who are stopping the drugs, the latest drugs, from being administered to the poorest of the poor. Now, coming to the insurance sector, I frankly, if I have to say that I'm not the right person to comment on that, because I am working in a government setup where the patients coming to me are not having any insurance cover. And I'm actually not the right person to comment on that.
Thank you, ma'am. We are noted, actually. That's why. I can give my 2 points on that. I work in a private center. So do I treat patients who got insurance, without insurance differently? Largely, no. because for both patients, I put forward the best possible option. And from then they kind of discuss, they tell us that, this is not this much that we can afford. It's just, our limitations. So according to that, we do have to kind of tailor that. End of the day, yes, I do feel that patients without insurance probably could have gotten a little better treatment. And I believe that every patient should be, insured either under the government or the private insurance, at least the government per se, and a little additional for the, for the private side as well. In Kerala, we do have multiple schemes, and we have a new scheme which is covering all the the state government employees, and we are able to cover most patients with that. But yes, you do compromise on treatment a little bit. I definitely discuss all the options, but practically you're not able to offer the best possible care. And I think we've completed our discussion and our questions per se. I'd like to thank our eminent panelists being so kind to join us this evening for the World Cancer Day program. I'd like to personally thank Shubnam, Dr. Pragya, Dr. Santosh, if he was here, and Mr. Sanjay Seth for sharing their opinions and definitely making this a lively discussion. To close, I just need a one line from everyone on World Cancer Day. It was told to me by the organizers. So, Mr. Sanjay, one line on World Cancer Day, or a take home message.
Well, of course, we are talking about cancer and its treatment and the insurance related there too. Being an insurance fellow, I would only talk from that perspective. As has been talked about by the doctors also, that in terms of cancer treatment or diagnosis, it has to be an early start, which is a very important thing. Same, I would suggest, is the situation with regard to insurance. Start early, take early, maintain regularly. Otherwise, you will pay very dearly. That is what is my message.
Okay, so wonderful. You came prepared for that.
No, because see, this is a message which I have been always giving in all my insurance, experience and my tenure as an insurer.
Yeah.
But somehow this doesn't register very easily.
Yeah.
It doesn't register very easily with the masses. We will try to use it every time. Thank you.
Yes, sir. Dr. Shubnam, any parting message?
Yeah. Parting message is that tackling cancer is an individual's responsibility, right? It is not the responsibility of the doctor or the government. It's an individual's responsibility. And it is a multi-stakeholder engagement which helps you to take care of yourself. You're not alone in it. You belong to a society. You have responsibility towards yourself and society. The pain in Pragya's voice when she spoke about the ecosystem and the environment exemplifies that. So number one, it's the responsibility of an individual to lead a healthy life. That's the first thing. And as Sanjay said, provide for it. We can't keep pointing fingers. It's government's responsibility. Doctor ne theek nahi kara, isne ye nahi kara. First, look at yourself. That's my
Thank you, ma'am. Yeah, point well noted. And Dr. Pragya, your one message on World Cancer Day.
So I will end with the slide that I always put up in all my presentations. It is cancer is not infectious. The knowledge about cancer is. So let's spread the infection about cancer awareness and wipe it from the face of earth. Yes. Thank you so much.
Thank you, ma'am. Yes, wonderful messages from everyone. Again, a big thank you to everyone who could join. And
A very warm welcome, everyone. I, Dr. 𝗕𝗥𝗚𝗗𝗚 on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. Voice of Healthcare, along with our supporting partner, AstraZeneca, has taken an initiative to bring together the experts and speakers for today's last session on Voices of Cancer Care, which aims to understand the emotional and mental impact of cancer on patients and how we can support our cancer warriors. Along with this, we shall also be honoring the voice of our hero, that is our cancer survivor, who shall talk about his journey in the battle against bone and soft tissue cancer. I would like to commence this session by introducing our eminent speakers. So, for this discussion, we have Ms. Vandana Gupta, founder, 𝗕𝗕𝗓𝗓 Foundation. Welcome, Ms. Gupta. Dr. Neeti Lekha Chhabra, founder and president of NGO Yes to Life. Welcome, Ms. Chhabra.
Thank you so much.
Ms. Vandana Mahajan, palliative care counselor, cancer coach. So she will join us in a bit, in just 5 minutes. And Abhiram, our cancer controller. Welcome, Abhiram.
Thank you, ma'am.
So starting with this discussion, I would like to ask Ms. Gupta, how does a cancer diagnosis affect a person's mental and emotional health?
This is a challenge I can assure you. The moment you hear that one has cancer, it becomes like a bomb has blown on your face, and you are only surrounded with bubbles and nothing else. So it's that type of a situation when the diagnosis of cancer is given to a patient. And most times, in our country especially, it's not something which is broken softly or explained well and all that. And also, our own prejudice about cancer, always like cancer is a killer. So you start with this now you've got a killer, you have to take a killer. So that is how the emotional thing comes up. And people begin to think that if I talk too much about my cancer, that I've become crazy and that I can think of nothing else but my cancer. But that is really, you're really sort of faced with an uncertain future in your life. And you don't know what is really going to happen, whether you're going to recover or not, what are the challenges that you face, what happened during chemotherapy. Of course, now much more is known, but I'm also giving you examples of when I had cancer, what all I had to face. But I would say that it is best that people who have cancer begin to think that there is a situation which has to be handled. So see, situation which has to be handled seriously. But you don't have to start living your life in a very serious way. It should be something that you can face and be, face bravely. Like, I always think of it that, you see a cactus plant and you admire it, but you don't go and sit over it. So you don't face the hardship, but you admire it. Of course, you can't admire cancer, but you can admire the situation because it can always be worse. So I think that is the most important thing. Of course, there are lots of challenges, like you may have, you may not sleep well, you may not eat well, you may keep thinking about the cancer all the time. It becomes the focus of it. And I think it's time that you need to meet a psycho-oncologist. There are a lot of people who are dealing with this who can tell you about your situation and who can help you in overcoming the cancer. The anxiety is caused due to cancer. So it's just not, it's on. So that's what they want. They want the cancer treatment to be taken care of and become the best treatment possible. But they forget that the human body is mind and the mind can wander everywhere. And so that mind is also to be taken care of, and a balance needs to be maintained. So if you have a good balance between a good mind and best mind to do treatment, I think that is what is the most important.
Yes, you have rightly mentioned that, when we first hear about cancer, there is a fear that is generated, and we should have a balance between our mind and emotional being to get the right treatment for cancer. So, Dr. I would like to ask you that what role can support groups and counseling play in the mental and emotional well-being of those who are affected by cancer?
Firstly, thank you for having me over, Ritika. So to answer your question, people do have a lot of problems generally in life, but then if somebody has a financial loss, one feels comfortable to talk to family, friends, relationship issue, it is okay to talk to your friends and family again. But for something as cancer diagnosis and treatment, you really need specialized support. While of course mostly family members will tell the person who's going through cancer, that everything is going to be all right and that's okay. But it is another thing to hear it from someone who's been through cancer oneself. So the best way I feel for a person to be made comfortable who's going through cancer is to hear from a person who's been through cancer, has come out of it. So when you hear it from that person that everything is going to be fine and you would be able to live a normal life after this, the kind of hope that it gives, it is immense. Because a lot of people, at least during the time when there is treatment going on, people do still feel, that they're in the hands of the doctors, there's treatment going on, they'll be able to come out of it. But I've seen a lot of people have fear of what happens after the treatment gets over. Because that is when you feel that you're kind of on your own from there, and I'm talking about people who have, stage 1, 2 or early 3 stage cancers, who do feel that the cancer treatment will stop at some point, right? And so when you hear that things can become normal, it really, really boosts up your morale to even go through the treatment. So I am a breast cancer survivor. And I remember that when I was to start chemotherapy, my doctor made me meet another girl. I got diagnosed when I was 31. So this is like around 10, 11 years back. So she was also my age, and my doctor made me meet her. That really helped me, because she was sitting so nicely on her bed, welcoming me like I'm a guest at her home, So that made me feel very comfortable, that it is not as difficult. Then I met so many women at the time when I was undergoing my treatment who had to undergo surgery. I had mastectomy. I lost a breast to cancer. So I could counsel so many women that it's going to be okay, and I could talk to them about whatever options are available to take care of your body image, etc. And I also strongly feel that emotional counseling should also be given to caregivers equally. I feel that caregivers are also under a lot of stress, both physical and emotional, of course. And if one, for themselves, and two, if they are able to remain in a positive mindset, that again will help the patients a lot, to keep their morale up and to take care of the whatever emotionally they're feeling down or they're feeling low. And I've also seen, since we counsel so many patients, that when we're talking to someone for emotional counseling, while there are dietitians available in the hospitals, there are psycho-oncologists available in the hospitals, still they start asking us about diets, they ask us questions that can be dealt with doctors also, because I think that we do provide for somebody who's been through it, can really provide a lot of emotional support. Even if you tell them that this is the diet that you can have, I mean, it goes beyond just giving them emotional support, is what I'm trying to say, because anybody who's been through it can really give that kind of support and empowerment to people who are going through the treatment.
Yes, you have rightly said that, someone who has been through it can give the exact kind of emotional impact that they have, and they can support the other people. So we have the honor to feature one survivor with us, that is Abhiram. So Abhiram, आप अपनी कैंसर जर्नी के बारे में हमारे सारे व्यूअर्स को कुछ बताना चाहते हैं. So we would like to ask you कि आपका स्टार्टिंग में कैसा रहा, आप कब डायग्नोस हुए, एंड हाउ यू हैव ओवरकम इमोशनल और मेंटल, वो सारा का सारा अगर आप बता सकते हमारे व्यूअर्स को.
यस मैम, मेरा नाम अभिराम है मैं जब बहुत छोटा उम्र था मेरा, शायद 4-5 साल का, तब मुझे कैंसर हुआ था 1992 में। तब मुझे उतनी कैंसर के बारे में तो याद नहीं है, लेकिन फिर भी मुझे थोड़ा थोड़ा याद है उस टाइम का, जब मेरे पापा ने बॉम्बे लेके आए थे टाटा मेमोरियल हॉस्पिटल। तो उस टाइम में हम लोग बिल्कुल अनजान थे, जो मुझे पापा बता रहे, हम लोग बिल्कुल अनजान थे कि मुंबई में टाटा हॉस्पिटल है भी कहाँ पे है, कोई जानकारी नहीं थी। जब हम यहाँ पे आए तो किसी के रेफरेंस था, हमारे गांव के कुछ लोग यहाँ पे रहते थे, तो उनके घर में हम लोग रहे थे। फिर वो लोग दूसरे दिन हमें टाटा मेमोरियल हॉस्पिटल बताए। जब हम लोग हॉस्पिटल में आए तो यहाँ पे उस टाइम में इतनी, जो आज को मैं देख रहा हूँ, आज इतनी पेशेंट नहीं हुआ करते थे, थोड़ा कम थे। तो उस टाइम में जब हम यहाँ पे फाइल बनाए हमारे पापा ने, तो उस टाइम में कोई इतना प्रॉब्लम नहीं हुआ था। फाइल बनाए, सब डायग्नोस क्लियर हो गया। फिर उन्होंने मुझे, डॉक्टर ने बताया कि इनको ऑपरेशन करना पड़ेगा। तो हमारे ऑपरेशन के लिए जब एक सीटी स्कैन टेस्ट होता है, जो सीटी स्कैन हुआ था उस टाइम में, तो डॉक्टर ने रिपोर्ट देखने के बाद तो उनको थोड़ा अलग लगा कि ये हम शायद इनका ऑपरेशन नहीं कर पाएंगे और बाहर से किसी को बुलाना पड़ेगा, कोई डॉक्टर्स को। तो उस टाइम में चार्जेस भी उनको बाहर में ज्यादा लगता। तो इन्होंने, डॉक्टर हमें, पापा को सब बात बताया कि यहाँ पे आपको हम नहीं कर सकते हैं, इसका जो केस है वो हमें बाहर से डॉक्टर को बुलाना पड़ेगा। उस टाइम में बहुत सारा खर्चा भी अगर बताए थे उनको, तो हमारे पास, मेरे पापा के पास उतने पैसे नहीं थे, तो उन्होंने बताया सब कुछ। तो ये डॉक्टर ने बोला उसका आप टेंशन मत लो, हम उनसे बात करेंगे। उन्होंने बुलाया, फिर उन्होंने आए हमारे सर्जरी के लिए। 9 से 10 घंटा शायद टाइम लगा था उस टाइम में, एक सर्जरी, मेरा सर्जरी के लिए। मेरा सर्जरी हो गया और मेरा बोन कैंसर था, तो मेरे यहाँ से लेके, चेस्ट से लेके एक पैर तक मुझे प्लास्टर हुआ था। और 1 साल तक मैं बेड पे लेटा हुआ था, मतलब सीधा एकदम, नहीं ऐसे हो सकता था, नहीं ऐसे हो सकता। वो सीन मुझे याद है आज भी, कि हमने 1 साल तक नीचे में देखा नहीं कि जमीन में, नीचे में बेड के नीचे क्या है, कुछ भी नहीं देखा। लेकिन वो चीज मुझे आज भी याद है, उतनी छोटी उम्र की बात। ये सब हो गया। फिर मुझे डॉक्टर ने एक साल बाद प्लास्टर काटा था। तो काटने के बाद फिर से मेरा टेस्ट हुआ 3 महीने के बाद, तो फिर से मुझे रिलैप्स हो गया 1993 में। जब रिलैप्स हुआ, मुझे बहुत ज्यादा पेन था, जो मुझे बर्दाश्त मुश्किल था करना। फिर भी हमने टाटा में आके दिखाया, तो उन्होंने बोला रिलैप्स हुआ है, फिर से हमें इनका सर्जरी करना पड़ेगा, लेकिन इस बार मैं इसका पैर बचा नहीं सकता हूँ। तो मेरे पापा अपसेट हो गए थे कि आप कोशिश कीजिए पैर बचाने का, तो ये बोले नहीं हो सकता है। तो फिर जो बाहर के डॉक्टर थे, उन्हीं को बुलाए। उन्होंने मेरे पापा को देखने के लिए, मेरा पैर फिर से बचाया गया, लेकिन उसके अंदर नस और हड्डी दोनों निकाल दिया गया था, सिर्फ देखने के लिए बचाया था। वो सब होने के बाद मुझे 3 महीने का शायद छुट्टी मिला था, मैं गांव गया। फिर 3 महीने के बाद जब बॉम्बे आया, चेकअप हुआ, मेरा सब कुछ बीमारी ठीक था। फिर 6 महीने के दिए, ऐसे करते करते 1 साल के दिए। उस टाइम में जब मुझे धीरे धीरे बीमारी के बारे में पता चल गया, कैंसर होता क्या है, जब मुझे पता चला, लोगों के मुंह से सुना कि ये बहुत डेंजरस बीमारी होता है, तो लेकिन मैं जब बड़ा हुआ तो मुझे कोई ये नहीं लगा कि मुझे कभी कैंसर था और मैं क्रेचेस पे चलता हूँ। मुझे कभी, मैं अपने मन में ये सब लाया नहीं कि मुझे इस चीज की वजह से प्रॉब्लम होगा, कभी मन में नहीं लाया। फिर मुझे ट्रीटमेंट के दौरान एक वी केयर फाउंडेशन 1995 में शायद मैं उनसे मिला था। एक अंकल करके आते थे, मुझे उनका नाम याद नहीं है, गाड़िया महाराज धर्मशाला में जहाँ पे मैं रुका था। तो उन्होंने शाम के टाइम में बराबर आते थे, मंडे के दिन शायद था, हमेशा हर मंडे को आते थे और सभी पेशेंट को बुला के काउंसलिंग करते थे कि ये बीमारी से कैसे ट्रीटमेंट किया जाए, कैसे ठीक हो सकते हो। बहुत सपोर्ट किए थे उस टाइम में, क्योंकि उनकी बात मुझे आज भी थोड़ा थोड़ा याद आ रहा है, क्योंकि वी केयर फाउंडेशन 1995 से शायद है, शायद मुझे उतना कंफर्म नहीं है, मैम को मालूम होगा, वंदना मैम को। तो उनसे बहुत लोगों को फायदा हुआ था। और उसके बाद जब मैं ठीक हो गया, तब मुझे एक शौक था कि मुंबई के कॉलेज में पढ़ने का। और मैंने यहाँ पे 2003 में मैंने कॉलेज, एमडी कॉलेज में एडमिशन लिया 11th क्लास में। फिर मैंने वहाँ पे पढ़ाई किया। फिर उसके बाद धीरे धीरे मैं संजीव सर से मिला। संजीव सर ने मुझे बताया ये कैंसर के बारे में तो मुझे पता था और मैं थोड़ा थोड़ा काम भी किया था, तो मुझे बहुत इंटरेस्ट लगा कि इस लाइन में इसलिए काम करूं ताकि मैं ये कैंसर पेशेंट होते हुए मैं समझ सकता हूँ दूसरे पेशेंट का प्रॉब्लम। और मैं संजीव सर से बात किया और उन्होंने बोला कि अगर तुमको इसमें जुड़ना है तो आ जाओ। मैंने उस टाइम से लगभग 2011 से इस क्षेत्र में काम कर रहा हूँ और मुझे बहुत अच्छा फीलिंग होता है कि इस क्षेत्र में मैं काम कर रहा हूँ। और जो पेशेंट आज मैं उत्सव फाउंडेशन में काम कर रहा हूँ, जो कैंसर पेशेंट के लिए गाइडेंस करते हैं, जैसा ब्लड, प्लेटलेट, एकोमोडेशन, फाइनेंशियल, तो हम लोग गाइड करते हैं पेशेंट को। बहुत सारा पेशेंट आता है हमारे पास, लेकिन उनको सबसे ज्यादा स्टार्टिंग में जो प्रॉब्लम होता है वो रहने की सबसे ज्यादा प्रॉब्लम होता है। तो हमारा कोशिश ये रहता है कि उनको कहाँ एकोमोडेशन दिया जाए, क्योंकि बहुत सारे लोग ऐसे रहते हैं कि उनके पास बिल्कुल पैसा नहीं रहता है, तो कहाँ पे कम में हो सकता है, कहाँ पे फ्री में मिल सकता है। तो हम लोग का काम वो है कि हम लोग बताते हैं कि कहाँ पे आपको मिल सकता है। तो ऐसे ही कोई कोई पेशेंट आता है हमसे क्वेश्चन करता है कि सर ये बीमारी ठीक हो सकता है क्या। मैं बोला कि आप सबसे पहले एक मैंने बी केयर फाउंडेशन से एक चीज सीखा था, क्योंकि उनके प्रोग्राम में मैं जब भी जाता था तो एक गाना जरूर हुआ करता था उस टाइम में। ये गाना का नाम था ये, इतनी शक्ति हमें दे ना दाता, मन का विश्वास कमजोर हो ना। तो ये मैं वो पेशेंट को ये बताता हूँ कि आप सबसे पहले आप विश्वास रखो, हिम्मत रखो, और दवाई तो है ही, लेकिन अगर आप में हिम्मत है, जज्बा है, तो ये कैंसर को जरूर हराया जा सकता है। और आपके सामने मैं खड़ा हूँ, मैं 25 से 30 साल हो चुका है मुझे कैंसर को हराया हुआ। और इतना ही नहीं, मुझे 2003 में कैंसर विजेता अवार्ड मिला था, जो वंदना मैम को मिला उसके बाद मुझे मिला था। तो मैं उनको बताता हूँ, उनसे बात करता हूँ, तो उनको जो थोड़ा एकदम इमोशनल रहते हैं, और जब मैं बताता हूँ तो उनमें एक अचानक वो बंदा में एनर्जी आता है कि अगर ये बंदा ठीक है तो मैं भी क्यों नहीं ठीक हो सकता हूँ। मैं देखा हूँ बहुत सारा पेशेंट को कि वो हंस के जाता है, तो मुझे बहुत अच्छा लगता है कि अगर मैं 10 में से 2 को भी समझा दूं और वो समझ जाए तो मुझे संतुष्टि होता है कि वो बंदा जरूर ठीक हो सकता है। तो मुझे सबसे ज्यादा पेशेंट को यही कहना है कि आप ये मत सोचो कि मुझे कैंसर है, खाली आप ये सोचो कि डॉक्टर जो बता रहे हैं उसके हिसाब से चले, और आप हिम्मत रखो, आप 100% इस बीमारी पे जीत पा सकते हो। यही मेरा उम्मीद है उन लोगों से।
थैंक यू अभिराम, आपने बहुत सारे व्यूअर्स को, हमारे बहुत सारे कैंसर पेशेंट, आई होप ये सब देख रहे होंगे, एंड आपने सबको एक होप दी है, सबको एक हिम्मत दी है। थैंक यू सो मच फॉर योर इंस्पायरिंग वर्ड्स अभिराम। So I would like to welcome Ms. Mahajan. Welcome, Ms. Mahajan.
Thank you so much, Dr. Ritika. My sincere apologies. I thought it was 12 to 1.
No, it's all right, Ms. Mahajan. So we started with this discussion. Now, I would like to ask you that what can be done to reduce the stigma associated with seeking mental health support for those who are affected by cancer?
Yeah. Thank you for raising that question, Dr. Ritika. It is such an important aspect of cancer care. Before that, I want to say a quick hello to Vandana ji and Abhiram. Keep inspiring. आप जैसे लोग हमें बहुत चाहिए to inspire others. So thank you. आप आए और आपने बात किया. Yeah, Dr. Ritika. First of all, it is very important to realize that cancer care, cancer diagnosis is not only the diagnosis of the physical body. So we need to recognize that as much as attention or treatment we are giving to the physical aspects of cancer, equal amount of awareness, equal amount of of involvement of the mental health issues is also related. So basically, we need to encourage equality between the physical treatment and also the emotional and the mental treatment, which doesn't happen in our country, sadly. So we have a huge gap in that. It's an unmet need, and we need to raise better awareness about it. Second would be to bring about a systemic change, Dr. Ritika. So when I was diagnosed with cancer, I remember I was diagnosed at 36. 36 is pretty young, when you have a small child with you. I went through the motions of the treatment, but there was no one to talk about how it affected me emotionally. And it was, I think, three years later when I myself realized that I needed emotional support. I needed to be treated for the emotional upheaval that I was going through. So I had the courage to walk up to a psychiatrist and get treated. I was under psychiatric treatment for 2 years. I did not know I could have sought counseling help also, Dr. Ritika. Most of the time, the emotional baggage that we carry from the time of diagnosis can very well be managed by including a cancer counselor or a psycho-oncologist or a psychologist who has experience in cancer field. So that is one way to break the stigma. Second would be also to include palliative care, integrate palliative care at the time of diagnosis. So maybe later we can talk about how palliative care continues to be a misnomer and very poorly understood concept in cancer care. That is also very, very important, because when we say palliative care also means providing holistic care to the patient. So the stigma can be broken by taking these steps. And also at the time of diagnosis, it's very important to tell the person being diagnosed that you need to empower yourself. Reaching out for mostly what happens is when you're going through the motions of cancer treatment, it's like a clockwork mouse. You are wound and you keep going through with it. 10, 11 months, 1 year, 10, 11 months, a year, sometimes more than a year. That time you don't realize what's happening to you. It's post that suddenly it strikes you that your life has been tossed all over. And that is the time we need to understand at the time of diagnosis that this stage will come. So I would say the best way to break the stigma is create equality between mental health and physical health, and also bring about a systemic change and empower the families that are affected by cancer, because cancer is a disease which affects not one single human being, the person diagnosed, but the entire family.
Yes, you have rightly pointed out that, it is not just a disease of the patient. So the caregivers are also affected by it. And it is not just a physical disease. The mental and emotional aspect of it are not acknowledged yet. So that is how people are not aware that, you should also be getting emotional support or mental support for this disease. They are just thinking of, going to the oncologist for treating the physical disease, but no one acknowledges the fact that there can be an emotional baggage that you have rightly pointed out.
So can I just a quick word here, Dr. Ritika? I'll cite an example here. A stage 4 patient that I was counseling, he was going through the treatment. He was responding very well to the treatment. But then one day he came to me and says, I don't want to go through the motions of the treatment because the doctor does not understand me. I said, now where is the problem here? So he says, I have an unmarried daughter at home. Okay. And that worry continuously eats my head, that what if I were to die? Who's going to get her married? So at this point, I think when a counseling support is also very important. So this is just a small example how counseling can help in holistic support of a patient.
Yes, you have rightly mentioned that counseling is the main thing which can help actually basically in making that journey not that much easier, but up to an extent it can, decrease some amount of baggage that the patient has. So with this, Ms. Gupta, I just wanted to know from you that what are the challenges faced by cancer patient in finding and accessing the support groups? You are on mute, Ms. Gupta. We couldn't hear you.
So I think you have to. Okay. Heartiest congratulations to Abhiram for all that he has achieved in all these years, because I have seen him grow up as a child, and I know what he was and all that. Probably at that time was not an issue with him. Okay, he was going through a treatment and he had to be treated. But the major issue and the emotional part of it was being faced by his parents. So I think as far as Abhiram was concerned, he was happy to be in the school that he done in the Pathshala, and he was happy to play his pranks and do things. But the support, and that it became important to keep them motivated enough to be able to do the work they were doing. अभिराम के साथ उनका काम जरूरी था. जहाँ तक support group का सवाल है, as Dr. Niti has mentioned, that being a support group is useful because there are people who you can share your experiences, and each age group has different like issues to be looked after. When the child is young, then that they are not looking, they don't understand the gravity of the treatment. It's the parents who have to be supported, like I said for Abhiram. As you grow older, then all your things come up, because whether your job issues are there, whether your marriage issues are there, or I know, like Vandana mentioned, there was this young boy who was not talking to anybody because he was very concerned about things. So his father came and met me, and I said, okay, I'll come and see the child. I mean, he was not like a child, he was about 20 years old or something. So we went to the room and we were talking to him, and he wouldn't talk at all. So I asked his father to go out, and then once the father was out of the room, he came and said that, ma'am, I have a girlfriend, and that girlfriend is not talking to me, and I'm disturbed about that. So then we had a session and we spoke. I mean, like we were talking, not like a formal session, but we were talking. And the more he spoke, the better it became for me to be listening to him. And I think at that point, he just needed a listening board so that he could, unburden himself and say whatever he had to say. And then after a couple of days, his father came and said that, now he looks much more cheerful. So the role of the support group comes in there, where you are an active listener. We don't have to be talking all the time. We have to be listening, because during the process of listening, there are so many issues that come out, so many things that we can hear, and so many things that we can understand. And maybe, somewhere the doctor's intervention, most places the doctor's intervention would be needed because that's what is concerning them. But at other times, it's just, our human touch which can make a difference in the lives of a cancer patient. Then, again, like Niti mentioned earlier, that caregivers play a very important role. And I think their support is extremely important, because as long as the patient is being treated, the caregivers are the ones who take all the efforts and who sacrifice either their jobs or, coming over. And it's a time-consuming treatment process. It takes a lot of time. So, and as soon as the treatment is over, the cancer patient feels he or she is fine and can carry on with life. And whatever sympathy or whatever empathy is there is with the cancer patient. But the caregivers are totally neglected. Some person who has sacrificed his entire life or career for the well-being of a loved one is now totally left in the lurch. And that is where the vacuum comes in. So if we as support group people can talk to those caregivers and understand what is the lesson that they are facing, that really helps. So the role of support groups is in all spheres. From the time the treatment starts, because that's when you need the information to empower the patient, to the time of understanding the age group, to the time of whether sexual intercourse can be done or not, because that's a huge challenge, but nobody talks about it. The doctors also feel a little reluctant to talk about it unless the patient brings it up, and the patients or the caregivers think that, it may not be a right thing to talk about it now at this stage when I'm having cancer, but it is in their mind all the time. So that has to be, brought out and spoken and all that. And jobs. What do you do for a youngster who has to get into a job? If he doesn't get a job, he's going to be emotionally upset because he hasn't got anything. So as caregiver, as support groups, we have information of where he can find the job. We may be able to connect people to get the right job and all that. So that should be our role, and that is where our data are being useful from the patient's point of view. Also, marriage, like I mentioned earlier, is a huge thing which weighs in the mind of people. In fact, we had started a site in one of the shadi.com things where people who had cancer could also register, and it was a separate page, and they could, find their partners through that website. So I think support groups play a major role in understanding, and we are not dressed as a doctor. I think that is the biggest thing, because then the patients feel very comfortable in opening with us. It's not like they are going to be judged by a person, and that their treatment may be affected because they have spoken very candidly to a person. That is the fear that most patients and caregivers have. Because if they ask any questions of the doctor may get upset. So here there's a person who's not a doctor and who's willing to listen and who has the knowledge, probably most times, to be able to answer their questions. So I think that's the role of the support group as far as the emotional aspect has to be looked at.
You have very, important, you have discussed a very important role of support groups that, it can help in every aspect of a patient's journey through cancer, providing them emotional support, a support to get married, or support with everything that is turning around in their life. So you have mentioned the importance of having the support group in case of a cancer patient. So moving on, I would like to ask Dr. Neeti that how can healthcare providers and other organizations partner with support groups to provide a comprehensive and coordinative approach to cancer care?
So I'm sure not just me, but everyone present here on the panel must have attended a lot of seminars, conferences that are being organized, wherein there are huge discussions about cancer care in India. For example, in terms of breast cancer, there have been so many, discussions whether we can make mammography a national screening or not, etc. But I have not seen this emotional health aspect being discussed on such forums. So firstly, I think that we must bring it to the forefront, and we must talk about it in such forums also, because this is something that would not even, the government would not even have to expend a lot of expenses, because there are already a lot of support groups existing. It is more a matter of tying up, finding the right support groups, finding the right kind of people for counseling. And you have counselors available in hospitals also. So first thing that I want to say here is that make emotional support also a topic that has to be talked about and brought to the forefront for discussions. That is when we can talk about emotional support at a national level, that how important it is to bring it up. Secondly, when we talk about a lot of private hospitals do have their support groups, but they are also not comprehensive support groups, which means that they do not cover all kinds of cancer patients, but kind of like breast cancer would have its own, support group for breast cancer patients, likewise some others. So one, of course, like I said, that these hospitals do have, but even for hospitals, the corporate hospitals who do not have their own support groups, they can tie up with other existing support groups. So we, like Life started in 2014. We have a support group that has around 150 cancer warriors. They are mostly breast cancer warriors, but they come from varied hospitals outside of Delhi also, so there's no boundary in terms of where do these people come from, or do they belong to a particular hospital or something like that. So first thing, like I said, bring this cause, this issue to the forefront. Two, all private hospitals also to tie up with other support groups. If the hospitals do not have their own existing support groups, so that they can send these people either to those counselors, or those support groups can go to the hospitals, once in a week to do the counseling for all the patients. Third thing here in point is, so we run a breast cancer center in Gurugram, wherein we reach out to all the women of villages of Gurgaon and around, which includes awareness for breast cancer. It includes, getting their screenings done, getting their treatments done, etc. Everything. We have been trying a lot to get data of patients, of already existing breast cancer patients, or who have, been through it at some point in time. And the primary reason was to provide them with counseling, to help them with lymphedema and other issues that breast cancer patients have. But we have not been able to get any help in terms of the registry, And we have been working with ASHA workers also. My point here is that all these ASHA workers, and this is not just in terms of breast cancer, but all types of cancers, when we're talking about people from lower income groups, all the ASHA workers, ANMs, they go to villages, house to house. Each ASHA worker has a certain set of households to her, wherein she goes, she talks about diabetes, and TB, etc., right? They could collect data of at least knowing as to whoever in the family has had cancer. And that data can be further shared. Not all the data, it is private data, I understand, not everything has to be shared. But these, whether at the level of PHCs, primary health centers, there can be tie-ups done with already existing support groups, maybe through a process of screening or whatever the government feels is right. But all of these people also need emotional counseling equally. Whenever we're talking about emotional counseling, it is either that people come to us through hospitals, or, some people get to know about us and they come to us. But if we want to reach out to everyone in villages also who's been through cancer and needs that support, there has to be intervention at a greater level. And we have been trying a lot to gather that data. There are people who come to us at the center on their own. We give them free prosthesis, bras, which I also feel is a part of counseling, for a person to have the body image back, to be able to go out in society, to feel confident, is also part of emotional healing. And also in terms of other counselings also. So if I know for us that if that kind of data is given to us, we would be able to reach out to so many more people than who we are reaching out now. So the role of primary health centers, ASHA workers, ANMs, all should be increased to gather data about existing, cancer patients in the society. And that is very easy to do because they go from household to household. So collecting that data is not difficult. The only thing is that it has to be made a priority. So these are some of the steps that I feel should be taken to improve emotional counseling and emotional support.
Right. So perfectly, said that you need to gather data first, and we need to change the system deep into. We have to go inside, and this can be done. Data can be collected through the ASHA workers, but the main issue here is that people do not talk about it because cancer, as I have asked before, that it creates a stigma in a person's mind. It's an emotional and mental thing first, apart from a physical issue, a physical disease. So that is, so I think the HCP can play an important role in providing the accessibility to these support groups, so that you can, because I think a positive mindset can also impact the treatment in every ways. If you have a support group, if you have a community around you that discusses about your matters and your emotional and mental needs, so you can, I think, more confident about the treatment. You will be more positive about it, and I think it can impact the treatment overall. So
just a point here, sorry. When we go to government hospitals for distributing prostheses, bras, etc., we get to know that these women had never ever been told that such a thing even exists, And not to blame anyone, but I understand that cancer burden in India is so high that the doctors also in government hospitals, their first point of view is to treat the person, physically. And then later comes other things, for which you need a lot of time and resources also. So I feel that when we, and I'm sure a lot of other organizations are ready to take up more of such burden from the hands of the doctors, to emotionally help people, it has to be a cumulative effort. It has to be a comprehensive effort wherein, we all partner in it, but there has to be a coordinated effort for which we need this basic minimum support that I spoke about.
Yes, because I think the doctor is also have burden of treating all the patients there. So these changes can come from small steps, and something some change in the policy can also be there, so that there should be a mandatory thing to tell all these things to the patient, and it can be made a priority with respect to the treatment that we are providing for the physical disease also. So change will come, but I think it will come in small steps. So so moving on to our last question today, I would like to ask Ms. Mahajan that what are the common challenges faced by patients and their families in the palliative care setting, and how do you address these?
Yet again, I'm going to thank you for bringing palliative care to the fore. Which is very, very important. We talk so little about palliative care that it continues to be very poorly understood or misunderstood. So the first thing, Dr. 𝗕𝗥𝗚𝗓𝗜, would be to tell people who are listening and spread the word around to make people understand what is palliative care. So I'm going to take 2 minutes or maybe a minute or so to, very simply tell our listeners what palliative care is. Palliative care, sadly, is misunderstood as end-of-life care, which is not the case. So palliative care basically is providing holistic support to any family that has been diagnosed with cancer. When we say holistic, I mean, providing symptom control, providing social support, providing spiritual support, because there's a lot of spiritual distress that also comes in, which becomes a part of psychosocial support. And then the fourth, I would say the pillar of palliative support is psychosocial support. So I would say the challenge that I face as an oncopsychologist is that people don't understand what palliative care is. So that is one challenge that I think we need to start by raising better awareness about what is palliative care. Second is the lack of intervention of palliative care into the main treatment plan. What happens is, because palliative care for majority of the people continues to be associated with end-of-life care, it is not integrated at the time of diagnosis. So for example, when Mr. A gets diagnosed with cancer, while the oncologist is treating the Mr. A for symptoms, there is a social worker who should be onboarded. Okay, so it is an interdisciplinary team. And as Dr. Neeti said, there are a lot of organizations, there are trained professionals like us who want to be providing that support to the patients. But the onus has to come in from the oncologist and the hospitals, irrespective of whether it's a private sector hospital or a public sector hospital. So it is very important to have an interdisciplinary team working with the main oncologist. So that is another challenge that I encounter, because by the time palliative care is brought into the treatment plan, most of the patients who are deemed fit for palliative care, Dr. 𝗕𝗥𝗚𝗓𝗜, are the ones who become terminal. Therefore, palliative care becomes equal to end-of-life care or a terminal incurable stage of cancer. So that is challenge number 2. Then I would also say it is the negative attitude towards palliative care, because palliative care is so poorly misunderstood or understood. So that also we need to change not only the mindsets of the healthcare professionals, but also the person and the family that has been given a diagnosis of cancer. Third is we also need to, fourth is rather, we also need to understand that the requirements of a patient when diagnosed with a curative cancer is different from the requirement of a patient who is probably stage 4 terminal at end of life. So that is another challenge that, I personally have faced, because until unless you have experts who can deal with, the emotional baggage that comes, at the diagnosis, early stage or late stage, we cannot actually claim to heal the patient. From a patient's perspective, Dr. Ritika, is most of the time when the doctor tells a patient that the intent of treatment is palliative, they've come up and asked me, am I going to die? So at that point, it is very important to tell them, because there are stage 4 patients who are doing incredibly well. Maybe 20 years back, a stage 4 patient would have been told you have limited lifetime span. Now with stage 4, with so much advancement in medication, patients continue to live a good life for many years together. So we need to educate the families that are dealing with the cancer diagnosis. Another very, very major challenge that I face, and I think a lot of my colleagues in health, in palliative care face, is what we call opioid phobia. There is a challenge. I think accessibility to pain is still very poor in India. That is another challenge which is there. But also, when pain relief is available, because of the phobia attached to maybe a morphine, is so big that the patients won't take it. So therefore, we need to create better awareness about yes, morphine is equated to a narcotic drug, which is equated to maybe an addiction. But there are a lot of benefits of morphine for patients who are struggling with pain or, symptoms at end of life. And not necessarily, it's at end of life. Sometimes cancer can bring about a pain, which morphine can help resolve. So that is another challenge which I feel exists in cancer care, and we actually need to close this gap also to raise better awareness about importance of palliative care. And like I said right in the beginning, we need to be proactive and integrate palliative care right at the time of diagnosis. It doesn't matter if the intent of treatment is curative or not, because emotional support and social support and spiritual support is as important as being treated for the physical symptoms. So yeah, that is the challenge that I have encountered, and I'm sure many of my colleagues in palliative care also face the same problem. So baby steps, and we need more forum like yours to talk about the importance of emotional support, how we can close the gap in terms of emotionally supporting people diagnosed with cancer. Lastly, I think what Vandana ji had said, the importance of support groups. I also want to add here that support groups also play a huge role in breaking the stigma of the need of emotional support, because people like me, when we are a part of support group, because I've been through cancer and I sought emotional support, that message goes out very well to others who are struggling with the disease. So that is another way of breaking the stigma, Dr. Ritika. So that's all from my side.
Thank you so much, Ms. Mahajan. You have wonderfully, busted the myth around palliative care, because previously, people used to think of it as the terminal thing only, that, only terminal patient can access palliative care. But as you have mentioned that, healthcare providers, along with, it is an interdisciplinary approach, patient can reach out to doctors, and then doctors can recommend patient support groups, palliative care groups for their emotional and mental support. But the main issue here is that patient themselves do not seek emotional and mental support. So that is we need to come up, the patient himself need to access it, because if we are not seeking emotional support, we are not bound to think about the positive aspects of life, and sometimes life starts after cancer.
Yes.
So that is the
So I'm sorry, I'm just interjecting. I know you are, approaching the end of this session. The intervention comes only when the oncologist will tell the patient, okay, you go meet a counselor, Dr. Риtika. The patient themselves, there are times when the patient refuses to believe that there is something emotionally wrong with them. Do you think I'm an idiot? That is what I've heard so many times. And when you start probing further, you realize that there are a lot of underlying issues that that manifest in various ways. And in palliative care, we have a terminology called total pain. So total pain is, a different aspect that I spoke about together. So in US, from whatever little I know, at the time of diagnosis, the patient goes to different members of the interdisciplinary team. So by the time the patient comes back for the treatment, a lot of issues pertaining to total pain have been either resolved or addressed, or at least shortlisted, so that we can simultaneously keep helping the family out.
Yes, so it's a matter of prioritizing everything in cancer care, I think. So because you prioritize medication, you prioritize the financial aspect of cancer, but you forget to prioritize emotional and mental baggage that it creates in the minds of
Ritika,
the
can I
cancer.
say something here? You know what happens is that because there is so much, added to cancer. Like there's the cancer treatment, there's the expense to cancer treatment. There is so many difficulties and challenges that the family faces, that a patient does not want to talk about their, if they have any mental problem. It's like a conspiracy of silence that you keep quiet. Okay, it's okay, I'll get well. Not realizing that all that is going to keep on burdening the patient in the long run. So while they are talking to anybody in the support group, I think it also becomes our responsibility to encourage them to speak about anything that is bothering them, because then they know that this is an issue that they can discuss, and that there will be somebody who will help them in sorting out that issue.
Yes, that encouragement is required from the caregiver side, from the healthcare professional side. So any encouragement that people can give to the cancer, warrior or cancer struggler, so whichever we want to call them, so that is how it should be done. Main thing is the first point of contact is the oncologist. So it is great to have these kind of advices come from the oncologist, because the doctor is treating it and there is a faith attached to the doctor with the patient. So that is how it can be. So with this, I would like to conclude this wonderful and inspiring session. Thank you, everyone, all the speakers that have come up, to deliberate this with us on World Cancer Day, and it's a part of National Cancer Conclave. So I would like to thank Miss Vandana Gupta, Miss Vandana Mahajan, and Abhiram. Thank you so much for inspiring us today, and be there for this wonderful and inspiring session with us. Thank you.
Thank you.